it another few seconds here. All right, I think we're good to get started. Welcome, everyone. I'm Jamie Strauss-Clark. I facilitate the Crisis Response Improvement Strategy Committee. And believe it or not, this is our 23rd committee meeting. So very good to see everyone. I feel like it's been a minute since I've seen all of you, and it's nice to see your names on the screen. We have a really special treat in store for you today. Our focus today is going to be on the behavioral health crisis response system for youth. And so we're going to have a panel discussion focused on that today. We have an action-packed agenda. So I want to go ahead and get us started right away so we don't lose any time. Christine, would you mind advancing the slide, please? All right, so you've seen these slides before. So I'm going to run through them real quick. We have two separate slides, one for CRIS committee members, one for community members and guests. So for this first slide, CRIS committee members, please, Christine, if you could just advance the, there you go. Please keep your mics on mute unless you're speaking in the meeting. Click ahead, please. Please, if you can, if it's available to you, please have your video cameras on, particularly during the discussion parts of the meeting. It's okay to leave it off during the rest of the meeting, especially if you're having bandwidth issues, but during the discussion, it's really nice for you to have your cameras on if you can. Advance the button. If you'd like to raise your hand to speak, please click on that reactions button and then indicate raise your hand. I will call on you in the order in which I see you raise your hand. You may also signal me this way, although it's easier for me to track when you use the electronic button. Advance it. You can communicate with me throughout the meeting via chat. CRIS committee members, community members and guests, I will not be able to respond to your chats, but CRIS committee members, I will be able to respond to yours. If you prefer to share a question or feedback in written form rather than verbal, please feel free to use that chat button and send it to me, Jamie Strauss-Clark. Click ahead, please. And finally, if you'd like to see as many CRIS committee members as possible when slides are not on the screen, please click that button in the upper right-hand corner and then change it to gallery view. All right, advance, please. This is the slide for community members and guests. Again, please keep your mics on mute throughout the meeting. The exception would be if you sign up to make public comment at the end of the meeting and I call your name to speak. Click ahead, please. And community members and guests, if you could please keep your video cameras off through the meeting, it makes it easier for me to facilitate with the CRIS committee members. Again, the exception is if you sign up to make public comment at the end of the meeting, I will let you know when it's time to turn on your video camera. Click ahead, please. Same instructions. If you'd like to see as many CRIS committee members as possible, click on that speaker view and change to gallery view. All right, a couple of other notes. We have two ASL interpreters joining us today and supporting our meeting for people who need some support there. We have Carol Williams-Love and Amber Baylor, and they will be pinned to your screen throughout the meeting. You can unpin them if you don't need that support, but it'll be available to you if you do. And then CRIS committee members, a quick reminder, when you speak today, if you wouldn't mind stating at the beginning, stating your name and role and representation on the committee before speaking, that just benefits everyone and reminds them who you are and why you're on the committee. I think that's it for the preamble. If you could click ahead, please, Christine. I'm just going to walk us briefly through our meeting objectives today and then how the meeting will proceed. So, of course, as always, our key objective is to ground our work in the personal stories and experiences of people who encounter the crisis response system. We will hear some updates from state agencies and subcommittees relevant to the CRIS. And then we're going to spend a good chunk of the meeting learning about the specific needs of and programs for youth and transitional-aged youth experiencing a behavioral health crisis, as well as recommendations from experts on what system expansions and improvements would best serve youth. We'll have some discussion time toward the end of the meeting to reflect and provide feedback on what we hear from our panelists today, and then we'll confirm some action items and next steps and hear public comment. It's like we heard public comment twice there. All right, if you could advance the slide, please. So here's how we're going to do the meeting today. We've gotten through the technology review. We're working our way through the welcome introductions and review the meeting agenda. And then we'll move into the personal story at 1:10. At 1:30, we have some system updates and some time for Q&A. And then you're going to hear a brief level setting on the crisis care continuum for youth. We've heard pieces of this throughout the year, but Sherry Wiley at HCA and Kashi Arora, our very own Kashi Arora from Seattle Children's, are going to bring that together for us, as well as 3 folks from our 988 call centers. And then we'll have our youth panel discussion. That'll be a little over an hour with some opportunity for CRIS members to ask questions toward the end. And then we'll take a short break at 3:15. At 3:20, we'll come back and have a discussion together about what we heard in that youth panel discussion. We'll do some group processing. And then we'll hear an update on CRIS extension and transition plan. Finally, action items, next steps, and then move into our public comment period. And folks, as so far today, I do not have any signups for public comment. If you would like to make a comment today, please send a chat to Christine Milana. She's in your chat message, and please let her know, give her your full name and any phonetic pronunciation, and I will call on you in the order in which you sign up to make public comment. We'll make a couple of reminders of that throughout the day. I think that covers, oh no, actually I do have I want to go over, sorry, if you could advance this slide, please. I do have a couple more things I want to go over before we move into the personal story. All right, just a quick reminder of where we've been and where we're going. So throughout the year, we've done a lot of work on system performance metrics and gaps. We've also done a deeper dive into substance use disorder and the relationship to the crisis response system, as well as rural and agricultural behavioral health crisis response. Today, so this box here, June 2024, we're going to be discussing the youth crisis response system. And then next month, we're going to do a similar deep dive into tribal crisis response systems, as well as some other aspects of system infrastructure, including cross-system collaboration, technology platform, and staffing and workforce. Advance the slide, please. And then in August 2024, we won't, in lieu of a large CRIS meeting, we're going to have smaller group discussions of the lived experience stories coming out of the Lived Experience Story Project and some recommendations for system improvements. And that is going to inform our next in-person meeting in September, where we will spend the day discussing draft policy recommendations as a foundation for the committee's final report that will be submitted at the end of the year, or actually at the first day of the new year. In November, we'll meet to review and provide input on the draft committee final report. And then finally in December, the steering committee is expected to approve that report and we'll submit it. And we'll have a little more information toward the end of the meeting, as I mentioned, about the CRIS extension and transition plan. All right, I think if you advance the slide, that puts us at personal stories. Wonderful, and I'm going to ask Kristen Wells to introduce our personal story for today.
Hello, everyone. My name is Kristen Wells. I use she and her pronouns, and I'm one of the lived experience representatives on the CRIS. I'm very pleased to introduce Leah Moshao today. She is our lived experience personal story for the meeting. She's an enrolled member of the La Jolla Band of Luiseño Indians and of Hispanic descent. She's a mother, teacher, and advocate for 4 beautiful children and a grandma, papa, or nam to 11 gorgeous grandbabies, 2 forever angel babies between the ages of 13 and the last 2 being twin girls that are almost a year and a half old. She's worked for the Department of Social and Health Services for the last 18 years. The first 6 were spent at Western State Hospital as the medical staff credentialer, and the last 12 years being at the Office of Indian Policy within the Office of the Secretary. She currently serves as the Tribal Contracts Manager and the stand-in for the Senior Director of Indian Policy. In her role, she is responsible for, most importantly, reminding others of the importance of how and why we work with the 29 federally recognized tribes of Washington State and ensuring that tribes are included in all the work that we do. With permission from her son, Amayas, she is here today in the capacity of a parent or advocate. Amayas has struggled with addiction for the last 15 plus years, which is about half his life. She wants to share the many different barriers that she encountered in February of this year and how we as a state have failed the addiction community of Washington State and the importance of ensuring that those who are struggling with addiction are getting referred to reputable places of service. So Leah, whenever you're ready, go ahead and start. And then we'll hear from the CRIS again at the end.
Hi, good afternoon. Thanks for allowing me to have this time. This is really hard for me. Harder than I thought it was going to be. I might take off camera because that might be a little bit more comfortable for me, but also because I know I keep losing bandwidth and I don't want you guys to lose any part of my son's story. I'll be reading off what I wrote, just so I don't forget any major parts of this. So with permission from my son, I'm here to share his story. On February 5th of this year, I received a call around 10:30 Monday morning from the local hospital that my oldest son was there. I did not know in what capacity he was there, dead or alive. I initially thought that I was receiving the dreaded call that my son was no longer with us. Fortunately, this time, that was not the case. Social worker informed me that he had been brought in via ambulance the day before and that he had overdosed. She then told me that I was able to see him. I went with my two daughters to come with me for support, not knowing what this was going to look like. When we arrived, we were taken to his room and we hugged him. He grabbed me tight around my neck, told me how scared he was. I had noticed that there was a meal untouched sitting by his bed. There were no sheets or pillows on the bed, and he was basically curled up with his knees to his chest as if he was cold. My daughter asked him for a blanket and pillow, which they then brought in. He then went to sleep for the next few hours. Not sure if it was from the high still or exhaustion of what his body had just been through. While he was sleeping, the social worker informed me that he had tested positive for meth, cocaine, and fentanyl. She then told me that he was medically cleared and that they were unable to keep him there just to sleep and that he was going to be discharged. I asked what her plan was and that he needed a detox bed to go to. She then told me how difficult it is to find available beds. I then felt the need to share with her where I worked, that I understood, but would try to find a bed for him along with her, and that between the both of us, we could find one. I made calls and so did she. And about 30 minutes later, she informed me that she had found a bed for him up at Fairfax in Kirkland. And if I was going to transport him, I live in Tacoma, which is about 30 minutes away. I told her that I would not do that, and if she could find transportation for him. My fear is that if he were to decide not to be a part of this, that he would get out of my car. She was able to, and she arranged for him to be picked up that evening. I went home for a little bit and returned with my 3 children to see him off. This was a Monday evening. I was calling daily throughout the week, and knowing HIPAA laws, knew that they could not tell me anything about my son, whether or not he was still there, even how he was doing. I just wanted for them to know that he was loved and had someone that cared. Saturday morning, I received a call from the detox center informing me that my son was still there and that he had basically been asleep for the last few days and that he was doing better that day. The caseworker then told me that he was to be discharged that prior day, but because of his condition, she pushed it to Monday. I then asked her about finding a treatment bed for him to go to. She told me that it's very difficult as there are not counselors to do assessments on the weekends. She then told me that there was a treatment center that she knew of that could possibly do assessments over the phone. She also had told me that when professionals had spoke with him through the week, that he did not want to go to treatment. I told her that if he's better today, ask him today, in which she did, and he agreed to go. I was then able to speak to my son, who told me he had no recollection of even being at the emergency room. He did remember hearing our voices, but thought it was there at Fairfax. He then told me he was willing to go to treatment. The caseworker set up a phone assessment for my son, and the treatment facility agreed to take him and pick him up that Monday. That Monday, I went to Fairfax to see my son, since I knew that there was a 30-day blackout period while he was getting picked up by peers of the treatment facility. While waiting to see my son, I had lots of conversation with one of the peers that was there to pick him up, sharing with him the importance of our culture, and that with the work that I do, I could possibly arrange sweats at the nearby tribe or assist in even having the young men in the treatment facility attend tribal events. I gave my cell number to him so that we could arrange these events. Eventually, my son came out, shuffling and looking very disheveled. My initial thought was that my son was stuck in this high and unable to come out of it. I hugged him, told him that I loved him, and that I would talk to him in 30 days. He was then off to the John Vulcan Academy, or treatment center that I thought it was. A week and a half later, I got a text from one of the peers that had picked him up, telling me that he had left the facility because he would not abide by the rules and that he had decided to leave. I checked his phone to look for activity. There was no activity. I was not sure where he was or even what to think. That evening, the peer texted me that he had returned, but then made to leave again the next day because he would not abide by the rules, because he just wanted to sleep. About 4 days later, I knew about where he stayed in Tacoma and was able to locate him. When he met me, he was standing in the rain, again, not like him, very disheveled. By this time, it had been about 3 weeks since the overdose. When he got into my truck, he took off his hat and showed me his hair. His hair was about an inch long. 3 weeks prior, when I saw him at Fairfax, his hair used to be to the middle of his back. I asked him what happened, not sure if there was a death that I didn't know about, since in our culture, some are known to cut their hair when there is a death. He told me that the peers at the treatment center, at the John Vulcan Treatment Center, had cut his hair because they said that was the rules, so he let them. His demeanor that day was of a 4-year-old kid that had been punished. I brought him home, where he stayed with me for 6 days, which during this time, he was able to only shower once and slept most of the time in between eating. During these 6 days, I contacted the John Vulcan Treatment Facility, quote, treatment facility, asking why they felt they could cut his hair. They said that was their rules. I reached out to their directors, CEOs from Arizona to Canada, because the facility in Kirkland, or in Kent actually, is where this facility is at. They blocked me from my calls. Asked them why. They understood the importance of hair in the Native American culture. They just said that this was their belief, that when you have dilapidated houses, that you don't repair them, you break them down to the foundation and rebuild. This is their reasoning for cutting his hair. And all the young men that are in the facility continue to question them. Since then, he came home. After the 6 days he was here, I reached out to a friend that I had made at the Puyallup tribe, Mona. She runs the Puyallup Tribal Reentry Program. Told her the situation about my son. She said, Leah, if he's willing, bring him Monday morning. We'll find him a bed if he's willing to go. So that Monday, my son was waiting for me next to my truck. He said, Mom, I'm ready to go. He was standing by my truck waiting for me. We went. We found a wonderful facility for him. He's in Spokane now. I'm glad to say that he's doing well today. He's in a very good treatment center. He has graduated his 12-week program. He's currently working part-time. He's in school, learning a trade. I can just say as of today, he's doing well. Every day is a new day, I think, every day. But after this situation, I've done some research into this facility and realize it's not a licensed treatment facility. And because they do not receive state or federal dollars, there's no one monitoring them, as they're a nonprofit, peer-led facility, unlicensed. As a mom in crisis, these are not things that I should have had to worry about. That where he was going to be a reputable facility, or that they were going to cut his hair, or if that was even something that we even had to worry about. I come with this story because I hope that it'll ensure that facilities that take in vulnerable adults should have cultural competency training, or at least knowledge of this. That is my son's story, and thanks for listening.
Thank you so much, Leah. My name is Bipasha. I serve on CRIS as a person with lived experience. Thank you, Leah. We were chatting right before the meeting, and you mentioned how hard this is. And that's the thing about being people with lived experience. We live our lives every day. We live in the thick of it. But when you have to take a moment to sort of reflect, you realize the emotional impact it's, taking on you and people around you. And it takes a lot of courage to be able to come and share these stories. And we're not just doing it for, some kind of shock value, but really to deeply implore the systems to listen to our stories so that we can have a system that meets us where we are. You are Native Indian. I am from India. There are so many different cultural practices that really do need to be considered. And especially things that jumped out from your story is when they told you, we asked him, he said no, but that was a few days back. And that's the process of, especially with substance use, have my work with being a crisis counselor on the regional crisis line is a person's frame of mind can change from moment to moment, and the system needs to know that. We need to tap in when people are ready, which is why we're trying to build a system that's solid so that when people are ready, the system is ready to hold them, to hold their families in space. That is the whole point of this whole journey with the CRIS. So thank you for that. Thank you for pointing out the specific cultural aspects of hair from, the Native tradition that you don't cut your hair. We have some parallel traditions in certain parts of India too. And also when you said, we think of people like buildings, and when it's dilapidated, you break it down to the foundation. I'm like, people are not buildings. No. We have stories. You can't break a story down. You can't take away my experience, my memories, my journey. You can't do that. I understand that, sometimes you want to bring it down to the simple aspects, the basics of a human being, but that just is like absurd to me. And of course, I have no answers as to why there are certain places that can do this without there being accountability. And you are still on that journey of figuring this out. And like you have said, and I want to end with this, you're not doing this for your son. I'm really glad that he's doing so much better now, but you're doing this for someone else's child, someone else. So thank you so much for that. Thank you for being here.
Leah, mother to mother, thank you for sharing your son's story, and please relay our gratitude for his generosity and giving you consent to share his story. These stories are always really powerful, but the ones that really get me are the mother to mother, the ones from mothers. So I feel you, and I'm very appreciative of you today. Thank you.
Like I said, it's been since February, and it's been almost 6 months, but it feels like it was just yesterday.
I'm sure it does.
It hurts every day, and like I feel like I'm doing better. Then you're just like, oh, it still hurts again, because every day is hope that he'll continue on the road he's on. I already told him he's not allowed to come back to Tacoma. He has to put a mailbox up in Spokane because he's doing well there. I try to see him when I can. I was able to see him about a month ago with his oldest daughter, who's 12, just to be able to see him. And I'll be seeing him again sometime in a couple weeks, and then I'll see him again in July. So I try to see him, but he's doing well. I'm just so appreciative of them getting him over there and setting all that up to get him there, and him agreeing to be there. But it's a hard road. Like I said, every day there's hope, and that he'll continue on this path. And I just keep telling him his stories, providing strength to a lot. And I told him, I said, you know me, I'm that mom. I will share it with whoever that we can learn from and build from. And so another mom doesn't have to go through what I've been through on many levels. I feel like there's holes in our system of that at the emergency room, they're willing just to discharge him. He hadn't even eaten a meal. Another meal had come in, and they were willing, they just said, well, he's medically cleared to go. And I said, he can't even hold his head up. Like, what do you mean? Well, he's medically cleared. And I feel like if I was not there pushing, that they would have just wheeled him outside and leaned him against a telephone pole. And I'm like, this is why we have the problem we have, that it's just a circle that they come back in the door because they're not being helped. And I just wanted that social worker to know that I am that mom. I do love and care that kid more than anything. It's my first love. He's 32 years old, but he's my kid. He's my kid.
It's always your baby, right?
Always. So but from that, to me, hole in that system was, I feel like there needs to be the warm handoff from emergency room to detox center, from detox center into treatment. Again, I felt if I was not there advocating, that he would have been again released from the detox center that Monday morning. And yes, he ended up into a terrible facility, terrible place, but it was a bed. It wasn't on the street. And that's where I have to kind of find the peace that no, it was not a good situation, but he's in a better place now. He's, like I said, he's in Spokane. He's in a clean and sober living. He's having to pay rent, and he's, again, doing well. He's like, Mom, if you send me anything, I've gained 40 pounds. Great. Great.
Well, please tell him he has 94 people here cheering for him.
Oh my gosh, his story has been shared. We are from a California tribe. I've shared his story with a young man who runs a program called Boys with Braids. He's out of California, and huge advocate. I was able to meet him in person last week at another conference I was attending. I have somebody from Oregon that reached out, and I was at another conference. By sharing his story, they've gifted me things to send to him on behalf of them, and said, please give this to your son. He's strength for all of us. And again, I'm that mom. Just, we got to do better. We got to do better as state, as society. We have to do better. And I'm so thankful for whoever called 911 for my son, because he told me he was in an alley and he just yelled for help. He said, Mom, I was losing control and I just yelled for help. And somebody called. They didn't have to call. They could have ignored him. They could have ignored him as another addict in the alley, another person on the street, but they did not. I have tried to reach out to, that mom. It ended up being about a few blocks down the street from my house where he was at. Had no idea this was going on. Called the fire department to get the address of where he was picked up. For one, he lost everything that he owned. He had his ID, so everything in his backpack, he lost all that. Some other person found it and picked it all up, and his bike that he had, they took that. But I had the address of where he was picked up and who called. And I have continuously for the last almost 6 months knocked on the door and nobody's answering. But I want to thank them so much because they saved my son's life. They didn't have to. They didn't have to. Again, this is hard. This is super hard, but I know it's also strength for me. I've told my kids, if you read through my bio, I've lost 2 grandbabies. And I am that mom and grandma. I have to be the strength for my kids. I'm a single mom, single grandma, basically. And so I have to be that strength, but I will tell them I will be that in whatever way it looks like. I can be that. You know, we've gone through things in our life and we have to continue forward. Yes, it's at a slower pace. I lost a granddaughter at 11. She was 11 months old to SIDS. And that was my daughter's baby. And she was a healthy baby and just didn't wake up. My other grandson, his name is Red Sky. He rests at the Colville Nation. And that is my son's baby who was born in addiction. So when I'm at the fentanyl conferences, I always write his name down and his mother's name and my son's name and my daughter-in-law's name, because my son has 3 kids with another young lady that was in addiction, but she's doing well now. I raised 2 of those grandbabies for 3 years, but they're doing well now. Mom's doing well. Mom's been clean almost 4 years, so she's had the kids back 3 years. But I'm able to see whenever I can. But we've had a lot hit our family, but we just have to continue forward and again, speak for those that you don't know. You don't know the stories that you share with people unless you share your story. You just don't know. But again, thanks for listening. I hope this helps make our systems better. Thank you, guys.
Leah, thank you. And here's hoping all the best for you and your beautiful family.
Thank you.
And lots of messages here from people thanking you for sharing your story today. I know it was hard and we're really grateful. And with that, let's move into our system updates. You should have all received the newsletter, so we'll have some time to check in with you on that. But before we do, I would like to ask Kristen and Bipasha they have a quick update for you on the Lived Experience Stories project, which is a very nice segue actually from Leah's story. So Kristen, Bipasha?
Oh, sorry. I just wanted to say we talked to y'all about the Lived Experience Stories project in April at the April meeting. I just first want to say that, it's been 2.5 years, and we are very glad to have had the platform for the Lived Experience Subcommittee. And we feel it's been beneficial for the community and also for the agencies to hear directly from the community. We've also had opportunities where the agency's been able to answer questions that we don't have answers for that the community has raised. When we came to you in April for the Story Project, we had a vision of 2 phases. Phase 1 is to try and gather as many stories as possible from different populations, especially from those whose voices cannot or will not show up at a once a month Monday meeting. I think that's part of our frustration with the process, and I'm not blaming anyone, just the way things work is we need to meet people where they're at, and that has not been the best thing to just say, show up on this Monday. And so we're especially wanting to hear from people who cannot show up on a Monday. And phase 2 was going to be a deeper follow-up with people about their stories, the goal being to hear about gaps in the system. Well, later today, we'll be hearing more on the upcoming changes to the CRIS process. And we learned about those changes and realized that we do not have the time to do phase 2. So we chose to stick to phase 1 and do it as well as possible. And we're asking for your help and support and connections to make that happen. Kristen, you feel ready to give the update? All right.
Yeah, so we're really excited to say that we did launch our project on June 4th, which is about 2 weeks ago, and we've had 22 submissions already. We have a robust demographic section that will help us track if we're hearing from folks from different backgrounds. And as we get submissions, we'll make time, I think, every other week to check what the demographics of folks that have responded already are, so we can increase our outreach to other populations that we can tell we're missing based on that demographic section. We know that sharing stories is a vulnerable process, but it's very valuable for us to be able to build a good system that truly meets the needs of our community. So we are able to compensate folks that participate with a $25 gift certificate for the first 200 stories that we receive. Our goal is to get stories that can help us see all the system gaps from the perspectives of people with lived experience and those that care for them when they reach out to the behavioral health crisis system. To do so, we're trying to reach out to as many folks as possible and encourage people to connect to their to any community they're a part of and share this if they're comfortable doing so. So to everyone here today, the CRIS members and the community members, if you could please share the flyer for this project, which should be posted to our section on the HCA website, but we might be able to get it posted to the PowerPoint with the meeting materials as well. If you especially are connected with any communities whose voices are typically left out of these sorts of things, it would be really helpful if you could try to connect with people that can submit their stories. Some of the communities we've identified that we don't hear from often are folks that are houseless or housing insecure. We don't get to hear from youth very often. Folks that don't have a lot of access to technology often aren't able to come to things like our lived experience subcommittee meetings since they're online on a Monday afternoon. It's not accessible for anybody. So if you are connected with or work with a community that we're not hearing from yet, we would love to have you provide the flyer for this project to them so we can hear from them about their experiences with the behavioral health crisis system. And if you have any questions, please let us know and we'll try to answer them as best as we can.
And folks, CRIS committee members, if you do have questions, maybe you could send them to me in the chat and I'll make sure I get them to Kristen and Bipasha, because we're probably not gonna have time for a full Q&A today. Thank you, Bipasha and Kristen, for the update and for all of your work on this. And now I would like to introduce Chantel Wang with the Department of Health, who's going to provide an update for you on the 988 communications campaign. So Christine or Devin, if you could put the slide deck up and on the slide, there we go. Take it away, Chantel.
Thank you so much. Hello, everyone. Good afternoon. My name is Chantal Wong. I hope everyone can hear me okay. I use she, her pronouns, and I am the 988 health educator for the Department of Health. So I work on a team of health educators who specialize in social marketing. So when you see advertisements on television, they usually promote you to buy some sort of product. My team uses the same techniques, but we're actually promoting a positive behavior change in the community. So I'm here today to talk about our awareness campaign, where we're at, and then where we're going in the future years. Awesome. If we could go to the next slide, please. Awesome. So before I get too much into where we're at, I want to give you a little bit of background context. So the Department of Health just launched our statewide marketing campaign for 988 awareness, and we launched that last month. So the overall purpose was we wanted to provide resources to people in crisis in Washington. With that, build awareness and drive action to prevent suicide. And then with that, we wanted to increase awareness, understanding, and usage of the 988 Lifeline in Washington, with the kind of underlying hope to reduce disparities within specific priority populations that have been disproportionately impacted. If we could go to the next slide, please. So I won't bore you too much with all of the details about what went into this campaign. But if you see that yellow star that says we are here, we are fully in the launch phase of our campaign, which means all of our advertisements, 30-second videos, radio ads, print ads, and newspapers, those are currently out in the world right now where you might be able to see them. But before we got to this phase, we had to do a lot of work these last several months. We had a lot of research done to learn more about what people have done in terms of promoting 988. We did a lot of awareness surveys for the people in Washington to learn, do they know what 988 is? Do they have any hesitancies in contacting 988? what would make them feel a little bit more comfortable to contact 988. And then overall, we wanted to make sure that we understood the landscape really well. Once we had all of those things done, we created a concept or an underlying flavor for our campaign. We had a lot of people with lived experience weigh in to make sure all of our materials were resonating appropriately, since those are the people that we're trying to reach. And we want to make sure that we can help them the best we can. Once all of our assets were created, and again, these are things like videos, social media graphics, radio advertisements, things like that. We sent them out, and they're currently right now live in the world. So it's very exciting. And again, we're really happy that this campaign is out there. And once it launches and once it wraps, we evaluate and do another report on if there's anything that we had missed. Maybe people had some comments about the campaign that we would like to have that insight on when we're moving into next year, if there's anything that we can improve on, or if there's anything people really like to see from us. So if we can go to the next slide, please. Awesome. So we do have this funding for a few years, and we have a couple of different audiences spread out throughout the next couple of years. So these audiences were decided on by the House bill that we got our funding from, but we also looked at Washington-specific data on what communities might be at a higher risk. So our current campaign is our year one audiences, who include veterans, people who identify as American Indian, Alaskan Native, people who identify as Hispanic Latino, members of the agricultural community, care networks and support systems. So anyone who might be around someone who might be needing support. Males aged 24 to 65, other communities of color, and then finally people who use substances. So those are our year one audiences, and I'll get into our plan for year two in just a bit. If we could go to the next slide, please. So before I get too much into the campaign assets and what we have out in the world right at this very second, I want to go over a couple of things on our campaign, one of them being our creative concept. So our underlying theme to this campaign is the aspect of human connectiveness, that no matter who you are, where you are in the world, human to human, we can relate that at some point we may have needed or currently need or might need in the future some support. And with that, we used a lot of the research that we learned in those first few phases of our campaign development, looking at key barriers that people who live in Washington have told us made them a little bit more hesitant in contacting 988. And we use strong motivators to help overcome these barriers. So for example, we want to make sure all of our messaging promotes that 988 is free and confidential, because cost and privacy were large concerns for people living in Washington when deciding whether or not to contact 988. Other areas included crisis counselors. A lot of people think that these might be physicians or therapists, and we want to be very transparent about how our crisis counselors are being trained. General information regarding who can call 988 and for what purposes. A lot of people don't know that they can call for a friend, a family member, someone they know and love, or even for substance use concerns. So those are all things that we really wanted to promote with this campaign. If we can go to the next slide, please. And now we have our campaign assets. So I'll run through them really quickly, and hopefully if you have time, we can see if the video chooses to work today. But this campaign will run until the end of July. And again, if you are living in Washington, you'll probably see a lot of these on a variety of different channels. So we have digital television, so streaming services, we have traditional television, we have digital audio like Spotify and Pandora. We have display banners on a variety of websites, radio advertisements, social media, Instagram and Facebook. And then we also have community-owned media. So some of our assets have been transcreated into 12 other languages, aside from English and Spanish.
2010.
And those communities wanted some materials that they could use in their own areas, where they might have radio stations or they might have local newspapers that are solely in their respective language. So we wanted to make sure that they have available materials for their own promotion purposes as well. So I have dropped the campaign websites if you want to take a look at them real quick. That's 198.org. And then on the website, we also have a partner toolkit. So these are all downloadable resources and promotion materials like videos, social media graphics that partners and organizations, or even for your own purpose individually, if you want to choose to promote them, they're available for you, which is really great. And I'm not sure, hopefully the video works, but I did want to share a 30-second video that has been shared on television and streaming services because it's very near and dear to my heart, and I feel like it is very powerful. So I would like to share that to you if it allows. Oh, I don't think the volume is working. I'm sorry. I still can't hear it. Can anyone else?
No, Chantal,
Oh,
maybe,
no.
do you have a link to that we could put in the chat and folks could go watch it?
Yes, definitely. I have the YouTube link. I'll put that in the chat right now. Send it to Christine.
And sorry, that was me that made that noise. I was trying to find it and I didn't have, I broke the muting rule, so I apologize for that.
Oh, you are totally fine. Okay, there we go. But if you get the chance, feel free to watch the advertisement. See if you can find all those little hints about the priority audiences that we're trying to reach within the video as well. Awesome. If we could go to the next slide, please. So that's kind of what we've been working on for the last several months. And again, we do have this funding for the next few years. So what's in store for year 2 that we can kind of expect? Right now, currently, we are awaiting for contracts to process an amendment for our year 2 funding. And then we kind of go back to the drawing board and start some of that process all over again. So for example, we have our year 2 audiences that will include youth and adolescents, young adults, people who identify as LGBTQIA2S+, care networks and support systems, older adults, age 65+, and other communities of color as well. For some of these populations, we do really want to make sure all of our materials are appropriate and they resonate well with people who might identify as one of those audiences. So we will need a lot of feedback again to make sure we're on the right page and see what people would like to see from us. But also because sometimes it takes a little extra time, especially if we're working with youth, that it might need a little bit of additional protocols to make sure we get the proper approval from parents, guardians, things like that. So we kind of start from the very beginning of that diagram that I showed you earlier of doing research, making sure that we have audience message testing and proper approval protocols. So that's what you can kind of expect for year 2. And if you could go to I think it's the final slide, please. If you do have any questions, comments, or concerns, I'm the primary point of contact. If we're not able to discuss it now, I'm not sure if we have time, but I'd love to have any questions be addressed.
I'm afraid we don't. We have a panel discussion and I do need to keep it on the schedule, but
No
Chantal,
worries.
thank you so much for
course.
walking us through all of that. And everyone we'll put Chantal's email address in the chat as well. Rep Orwell, I have to really stick on the schedule. Do you have a quick question or comment you could ask, or is it something we could relate to her later?
Well, I just kind of want to share this. One, thank you for this great work, but the telecom is waiting to be approached because they're willing to do all the 988 ads free on radio and TV. So I want to make sure we can connect and happy to work with you, but great work.
Yes, that would be wonderful. Thank you so much, Rep Orwell.
Chantal, thank you so much for your time today and your great information. I'm just going to put that email address in the chat for everyone so that you can email Chantal with any questions or comments on the presentation she gave us today. Thank you. All right. And CRIS Committee members also, if you have any questions from the newsletter, please do send them to me in the chat and I'll make sure I relay them to the appropriate agency lead and we'll maybe have the answers to those questions in the meeting summary. And sorry for rushing, folks. We've got a very action-packed agenda today. Let's move on. So our next agenda item is to set up our panel discussion conversation. We want to provide a reintroduction or re-overview of the crisis care continuum for youth. So here's how it's going to run. Kashi is going to set us up, Kashi Aurora, by reminding us briefly of the map of crisis care continuum for young people. And then we have Courtney Colwell from Volunteers of America Sarah Schumacher from Frontier Behavioral Health, and Diane Mays from Crisis Connection. So you'll recognize those names. Those are our 3 988 call centers. And they're going to be sharing protocols for responding to calls from youth or third parties calling on behalf of youth, plus some feedback that they received from the Children and Youth Behavioral Health Work Group on those protocols. And maybe a little information on numbers that are getting around texts and voice calls. So that will be happening after Kashi's introduction. And then Sherry Wiley with Healthcare Authority is going to wrap up by reminding us about the MRSS, the Mobile Response and Stabilization Services Program for Youth, the model for youth. And that will set us up nicely for the following agenda item, which is our panel discussion. So with that, I'm going to turn it over to Kashi.
Thank you. Let's see what's on the next slide. Perfect. Okay. Nice to see you all. Kashi Aurora, she, her pronouns. I work as the program director for the Behavioral Health Service Line at Seattle Children's, and I also serve on the CRIS Committee as the state's Children Youth Behavioral Health Work Group representative to this committee. I won't talk about this for very long because I want you to really hear from those who can speak to current state of the practices for responding to youth in crisis, and then really excited for you to hear from panelists. But thanks to Sherry Wiley for this slide. This is a visual representation of what we've been talking about for the 988 or crisis system, that we want youth to have someone to talk to, someone who can respond to them, and a safe place for them to be. And really critically there in that center circle is the self-defined crisis. And that could be the youth defining the crisis or the family defining the crisis. And I think for me, when I look at this, I think about what exists currently. And there are people to talk to, where there are growing teams to respond, which is very exciting. I think Sherry will cover some of that in her updates. And we need more safe places to be, and we still need connections between all 3 of those elements of the system. How do you go from the person you're talking to the person who responds to you? How does the person who responds to you know for sure the resources that are available in terms of safe places you can be or receive care, and vice versa? So this brings a lot to the forefront of the conversation, and I'm really excited for you to hear from others. But I think right now it's really important to remember that in places where there aren't people to respond, or in places where youth are not getting connected to someone who can come be with them and their family, or them and their chosen family wherever they are, there are very limited options for crisis response. And for many kids, that is just the emergency department. And that is a significantly suboptimal place to receive behavioral health crisis care. As somebody who worked in an emergency department. So this gives you, I think, an aspirational picture of what we should have. I would not call this current state. And I think we have a lot to do to get there. So I'm excited for who you will get to hear from today. Jamie, I'll pass it back to you.
Wonderful. Thank you, Kashi. And now I'd like to introduce our call center team. So Courtney, Sarah, and Diane, who have a presentation for you on call center protocols related to youth and transitional age youth.
Hi there. I think we did submit some slides. So are you going to transition to those for us? There we go. Thank you. And I'll start out because I'm the unofficial designated spokesperson to start, but I'm Diane Mays. I'm the clinical director for 988 Crisis Services. And then Sarah and Courtney also here as well. I don't know if you want to introduce yourselves too.
Sure, I can introduce myself. Hi, everyone. I'm Courtney Caldwell, Director of 988 Services at Volunteers of America. And I do believe Sarah is out today. Okay. So it's just 2 of us.
Just the 2 of us. Okay, so Courtney and I will tag team this today. So thank you. You can go ahead and advance to the next slide. So just want to start off by a reminder. In the last year, we have certainly expanded our outreach and ability to connect with contacts across the state. So we all started off with our phone services back in July of 2022. Now we also have added the additional chat text services at Crisis Connections, joining Volunteers of America, as well as our diversion projects that we have in 3 different 911 centers around the state. So really expanding our outreach and really excited by this opportunity, because we definitely are seeing an increase of contacts across the spectrum, but particularly with youth contacts, certainly with the expansion of the chat and text services. You can go ahead and advance to the next slide. So touching base on our youth response and our protocols when we get youth callers. Again, we, as consistent across the 988 Lifeline, we as the contact centers all have have a significant amount of training that our call teams or our crisis teams, I guess I would say, connect with youth. So we do have significant training, including youth content. Vibrant also provides a number of tip sheets, Lifeline tip sheets when connecting with contacts, and webinars that we can also use for self-paced learning or informational updates to keep staff current on topics that may come up with youth and any changes to the working with the population. And then there are also impacts for or resources for LGBTQ plus youth and guidelines, including inclusive language tip sheets. So I shared the link in the presentation for on the Lifeline website in general for a youth page, landing page that they have. So if you are directed to the 988lifeline.org, there are a number of resources available to them there. And then we also have a number of state and local resources that we use within our centers. And so we are really able to lean into those and provide those for the youth who reach out to us and contact us. And in reality, I think, you know, again, each organization would have their own additional trainings that they do above and beyond what we have with our youth guidelines. Some of the pictures that I show here on the slides are from the Lifeline specific resources that they also encourage us to use outside of our organization tools too. And then for all youth, in terms of protocol, any youth or any contact that we received by a youth who's under 18, they do require clinical observation. So for us at Crisis Connections, they can raise their hand. They indicate to a clinician that they have a minor on the phone or on chat text so that we can have them available to provide additional clinical guidance and support in making determinations when potential next level of care are needed or specific resources in each instance that may be necessary for the contact. And again, following Lifeline protocols, all contacts are assessed for safety. We meet the contact where they are, really work to establish and build rapport with them, to get to learn about them, to make that connection so that we can have a conversation with them, whether it's by phone or chat or text. And this would also apply in the case of third-party contacts as well. If a parent or a guardian or someone of concern is going to reach out on behalf of a youth, then we're going to do our best to connect with that person, gather the information they share about the person of concern, but we're also there to support them in the process. And if the person of concern that they're contacting us about happens to be available, we would also ask for them to maybe engage in the conversation with us so that, because we know that by having them participate to engage in their care is one of the best ways to help them be successful in getting the support and the connections that they need. And I think those are kind of key things. Courtney, is there anything you'd like to add to that as well?
Nothing to add in terms of protocols. I think our 3 crisis centers are pretty aligned in the way we approach calls, chats, and texts from youth. Chat and text is a really good resource for youth. Historically, we've seen that over 50% of the clients accessing the chat and text service tend to be under the age of 18. So there are some general kind of barriers to data collection for chat and text due to limitations in the unified platform we use, hosted by Vibrant, something we're continuously working on. And like Diane mentioned, we definitely make an effort to collect demographic information, but we do experience general barriers to that just due to the fact that we never want to create a potential barrier to the help-seeking process by making clients feel like they can't remain anonymous if they choose to.
Yeah, you can go ahead and advance to the next slide. And then in terms of, so as we know, in the entry to the crisis care continuum, we are the someone to talk to, right? So there we're going to be that first point of entry for most contacts who are reaching out for help or for support. So a couple of options that we have available for the resource landscape, and particularly when an in-person response is requested or required in King County, where we serve for Crisis Connections, is we offer an opportunity to connect youth contacts to the Children's Crisis Outreach Response System, or CORS. And this is run through the YMCA, and this is a great organization to get youth directly connected to care. And then we also have the Youth Mobile Crisis Team Dispatch. And so we know that those services have expanded across the state as well, which is a great benefit to everyone reaching out. And these, for the 988 side of the house, we would receive these contacts. And in our regions, we would have MOUs to be able to do the direct referrals for the mobile crisis teams. But in other counties where we are not the primary contact, we have the ability to connect the callers to the regional crisis line so that a referral can be made directly in those areas or in those counties as well. So say we're in King County, we get a contact from someone in Pierce County who needs a mobile crisis dispatch, then we can refer them to the regional crisis line, do that transfer over to them so that we maintain that continuity of care and can dispatch that service directly through that connection. And Courtney, would you like to expand on BOA's resources?
Yeah, it's pretty much the same process, and definitely a second to what you were saying around the vision for a no wrong door approach. We never want what number to call to be a barrier to anyone seeking help, whether it's 988 or regional crisis lines. We do have that ability to warm transfer and stay with the client as long as possible through that process if they should need resources provided by a regional crisis line that's outside of our immediate service region.
And to add to this, when it comes to follow-up, so part of the 988 protocols is that we do offer follow-up care for contacts. And so youth contacts are treated the same as adults. They are offered the opportunity to receive a follow-up call or outreach and from our follow-up specialists. And we do have to ask for consent for those. So if there is consent for that, we will do the follow-up call to see that they've been connected to their care, one, to check in and see how they're doing since they've contacted us, since they've spoken with us, see if there's any additional support needed, and if they've been able to follow up and get connected to the other resources that we may have referred them to, including the mobile dispatch teams as well. And you can go ahead and go to the next slide. And as I mentioned, we are that point of entry. We are that someone to talk to. So it's a wonderful resource that we've been able to expand over the last 2 years since we started to really add more services and more opportunities for contacts, particularly youth, to reach out to us. And as we mentioned, the chat text has been a really seen a really big impact in that population. And some things that we are certainly proud of in the work that we've done over the past couple of years is being able to offer that safe, non-judgmental space for youth in crisis and who are reaching out to us for support. And we're able to help identify there are some gaps or barriers maybe to some challenges that we have in supporting youth, such as transportation, maybe natural support such as parents or an adult in their life that may be someone who is there for them in their time of need, and oftentimes financial barriers as well. So when we learn of those resources too, we try to lean into, or those needs as well, we try to lean into our essential services or other resources that can help support them. But really the biggest feedback is that they feel safe and they feel comfortable talking to us, and that we're able to meet them where they are and speak to them on their level and listen and be able to connect them to anyone who can help them out and give them support at critical times. And I would say that our team also feels really proud of the interactions when the youth, youth walk away from the conversation feeling empowered that they also have tools and maybe a safety plan or resources that they can lean into on their own and help participate and manage their own care and support as well. And Courtney, is there anything you'd like to add to that as well?
Yeah, thanks, Dan. The only thing I'll add is that all three 98 centers in Washington State have really focused on youth in our community engagement efforts. So for example, our community engagement staff have been actively working on maintaining a presence in middle school and high schools in our service region. And this is things like hosting a table during lunchtime, facilitating trainings on what 988 is and how to connect yourself or a friend to 988. And then just something interesting, our community engagement coordinator tallied the top 3 questions asked by youth over the last quarter during these youth-focused events. And these were: 1, can I call if I'm not suicidal? 2, what if I don't need help, but my friend does? And 3, how does chat and text actually work? So those are the most common questions recently asked by youth.
And I would support what Courtney said, that in the community engagement. I recently was at an event in Kent. We have a couple more coming up in the next few weeks, and even partnering with our diversion team. And I would say a large majority of the conversations we had were with youth or and parents with their children. We were at the Kent International Festival recently, and so it was a lot of families out for the day. And we had a table full of the Crisis Connections services across the line, but they were very interested in receiving more information about 988 specifically, wanting the magnets to stick on their refrigerators and the bookmarks so that they could take them and stick them in their school books and have them available as a resource. To call, to know who to call. And we also, as an organization, have a guidebook for our Teen Link services, and those are very popular at our events, to have just a teen dedicated resource manual of organizations and phone numbers and things that they can look into and reach out to on their own, or to have an adult help them with those connections as well. And you can go on to our last slide. Sorry, I had one more thing for a challenge. Sorry, I did just, and then we can talk about on this slide, but as someone to talk to, one of our challenges that we do also sometimes face is once we've bridged that gap and made that referral to a mobile crisis team or to an outreach team, we have sometimes heard feedback that they've, called 988 and maybe didn't get the service they were expecting or have the outcome they were expecting. But what we're often finding in that is that gap between once they're transferred from us to the mobile crisis teams or to the other outreach units, the disconnect is happening on that end. So again, we're doing the best to bridge the gap. So we always try our best to either reconnect them to that service, or could certainly see ways that we, would like to find ways and discover ways that we can make those transitions smoother so that it feels like a seamless transition across the organizations. And with that, you can go to our last slide. And so that is, highlights of our youth outreach and what we're doing right now. Certainly happy to answer any questions or be available for any feedback that we could receive.
Thank you so much, Diane and Courtney. Really appreciate the presentation. Everyone, I put the email addresses in the chat so that if you have questions, you can relay them to Diane, Courtney, and Sarah. But really appreciate all the good information you shared with us today. I think it sets us up really nicely for the panel discussion shortly. Thank you so much.
Thank you.
All right, and next up is Sherry Wiley with Healthcare Authority, who's going to provide a brief recap, a reminder for us about MRSS, the MRSS model. And Sherry, I hate to do this to you, we are running a little bit behind, so if there's anything that you can do to sort of accelerate, that would be great.
Of course. Thank you, Jamie. Thank you for having me. My name is Sherry Wiley. I'm the Youth Mobile Crisis Team Administrator here at Healthcare Authority. I'm working on the Crisis Systems team for rolling out 988. And I come to you with a history of being a paramedic. So I used to go and pick up kids after, things would happen. And then after my marriage and family therapy degree, I ended up supervising and delivering youth mobile crisis here in the state. So I'm going to go over youth mobile response and stabilization services. I'm going to use MRSS for time. Youth crisis can be heavy. I want you to take care of yourselves. And I want to give a shout out to Leah. I thank you for sharing your story. Next slide. As the single state authority on behavioral health, the programs that Healthcare Authority administers for youth and families are developed with the input of youth and families. So we're proud to partner with Spark, a Common Voice project in Washington State Community Connectors and MRSS design and rollout through a System of Care grant. Next slide. Here's some common reasons a caregiver might call a crisis line: suspensions, destroying property, suicidal ideation, maybe a parent's unable to work due to frequent daycare behaviors and they have to pick up their kid, isolation, school refusal, cutting, not listening after transitions. So parents may not have the language to describe a crisis in a clinical way like adults do, and we don't want them to have to learn how to do that before they get help. Next slide, please. Healthcare Authority contracts with 10 behavioral health and administrative service organizations to provide crisis services. And these services are operating right now as we speak. These include regional crisis lines, crisis response teams, and involuntary treatment services. Next slide, please. Crisis services to date are historically adult-centric. So acute presentations result in expensive facility-based care and frequent contact with law enforcement or the justice system. Because when you intervene, when people are acute, symptoms appear as noncompliance. So when people are that acute, they also become a danger to themselves and others, and then they're involved in involuntary detainment through a legal process that sometimes ends up in where they end up in hospitals for months waiting for definitive treatment. Next slide, please. This group is well aware of the legislation, but I want to highlight two things on this slide. In 2021, the Youth and Young Adult Continuum of Care made recommendations to legislature, and proviso funding was allocated to ensure at least one youth and one adult team in each region to respond to calls coming into 988. In 2022, SAMHSA and NASHBID released companion reports for youth best practices in crisis care. Next slide, please. Can you click that for me, Jamie?
Kristen, can you click that?
Yeah.
There, oh, beautiful.
So, yeah, so healthcare went ahead and sent out that proviso funding. This time, 2 years ago, we only had 4 youth teams covering 5 counties. And if you click the slide again for me. Today, we have 14 youth teams covering 18 counties and growing. These youth MRSS teams reduce reliance on the adult crisis system, the involuntary treatment system, and 911. Next slide, please. As Kashi stated, the adult crisis model, well, the youth crisis model is someone to call, someone to come, and a safe place to be. So for youth, we don't want to transport them anywhere. Core principles include a no wrong door, a single point of access that's not 911, and the youth and the caregiver, not the call taker, define the crisis. Youth are assessed for risk in person, peer support is built in, and MRSS is developmentally and culturally appropriate, trauma-informed, and equitable. The SAMHSA Crisis Now model assumes an in-person response for adults at 20%, and MRSS is the inverse, with in-person response at about 80% for young people and their families. Most youth teams in the state are meeting that metric when they're accessed through the regional crisis lines. It's at 80% because we recognize that young people do benefit from confidential talk, text, and chat support. Next slide, please. So the goals of MRSS is we're going to reduce the use of emergency departments, inpatient stays, and juvenile justice involvement. Teams support and maintain the youth in their current living situation, and kids sleep in their own beds and go to school while they're being stabilized. Teams are going to promote safe behavior in all the spaces youth are in, and they're going to assist families in accessing ongoing care. And they also do outreach and engagement with system of care partners. Next slide, please. There's 2 phases to MRSS. It leverages both crisis intervention and crisis stabilization in our Medicaid state plan. So a caregiver has the right to request and receive evaluation of their minor child, including crisis services. This is no different than them taking that youth to the primary care provider. MRSS is going to meet a sense of urgency with urgency. When families call, teams are going to go. They're going to respond, and this is consensual and it's voluntary. They're going to respond with a dyad of a clinician and a parent or youth peer. And the team's going to engage the youth to direct their own treatment. Teams provide developmentally appropriate assessments, determine strengths and needs, de-escalate, do safety planning, and can help support caregivers to keep that youth safe at home. The peer supports occur throughout the intervention. Teams will go wherever the youth is. So if schools call, teams will respond there. If there's a school issue, these MRSS teams can get a meeting the next day with the school, the youth, and the caregiver. If the family consents, the team can follow up for up to 72 hours, and they have access to a clinician 24/7. All these interventions are supervised by MHP supervisors 24/7, so mental health professionals. Next slide, please. If after the crisis intervention phase, the youth or family needs more support, there's a separate but connected in-home stabilization phase for up to 8 weeks. Teams provide ongoing peer support, connection to family and youth organizations, brief therapy, skill building, psychoeducation, care coordination, and they're going to work with that family to identify and connect them to natural supports through wraparound principles. They're going to make referrals and provide warm handoffs to the right level of clinical care to ensure connection, thus preventing return to the crisis phase. What this looks like is driving that kid to that outpatient provider, supporting them through the intake, or sitting with them in their living room and doing it together on the laptop. We want to ensure connection before that intervention's closed. Next slide, please. This is often the first contact a young person or parent has with the behavioral health system. So we need teams to be responsive and earn their trust so that they'll call back. MRSS teams connect the family to supports in their region, including peer support. We want the right level of care at the right intensity and delivered at the right time. MRSS can change a young person's life. These 14-year-olds are going to be 18 in 4 years. Do we want them to age into the adult system in juvie, not graduated, not knowing how to access regional providers? We want that young adult to have a good experience so that they seek treatment in their lifetime. If families are calling a crisis line over and over, they may not be getting their needs met. So a successful intervention can be measured with reduced contact with the crisis system. Next slide, please. Anyone can make a MRSS referral. So all of these system of care partners in every region should know about and how to access your youth teams. Next slide, please. MRSS teams are contracted to have parent and youth peers with lived experience, either receiving treatment themselves or supporting their youth with behavioral health needs. I'm a clinician. I can't share my personal story, but youth and parent peers are going to share their stories in a way that provides validation, support, hope, and self-empowerment. If your kid's in crisis, it's not something you're going to go to work and talk about with your peers, but a parent peer has been there. A parent peer gets it. They understand. Healthcare Authority did a state plan amendment, and we added peers to both crisis intervention and crisis stabilization in our Medicaid state plan. Next slide, please. It may seem like over-the-phone resolution is least restrictive, but for youth, an in-person response is considered least restrictive, and I'm going to show you why. Young people are system involved, so the adults in their lives are the ones who identify needs, and then they send or direct caregivers to take them to the emergency department for evaluation. If a parent calls a crisis line and they don't get what looks like help, they're going to hang up and call 911. You're going to ask Adam Wasserman. 911 will send EMS, police, or fire. And again, they're going to transport that youth to the emergency department or worse, juvenile justice. We want to limit any uniformed response with youth. Before the pandemic, I think you all be surprised to know that Washington State was arresting over 11,500 youth per year between the ages of 12 and 17. We know that 85% of those youth involved in juvenile justice have a diagnosable behavioral health condition. The emergency room leads to more restrictive out-of-home facility-based care. Kashi will be happy to talk to you about all the young people boarding in hospitals right now in the state. And the Children in Crisis Bill 1580 was passed to address that. So we want to shift from sending kids with any safety risk to the hospital to understanding that we can keep kids safe in their current living situation. This way, those limited inpatient beds are available when kids really do need it. A 2022 study by Mary Bridge Emergency Department in Tacoma found that for youth that went to the emergency department that year for behavioral health needs, 61% of families reported negative functional impacts due to the long lengths of stay. 33% of youth reported that the visit wasn't necessary or it made things worse. The study concluded that the top possible diversion was mobile crisis outreach at 98%. Next slide, please. Youth rarely refer themselves to a crisis team. They are living their best life, even when they're doing things they shouldn't be doing, and even when they have some behavioral health symptoms starting to creep up. In my experience, the only youth that are going to refer themselves to a crisis team are the ones who have gone through MRSS, and I've gotten calls from kids in other states who had a great experience and they're trying to help people in their state. So it's the adults in their lives that are going to refer kids to youth crisis teams. Through a recovery lens, anyone can call a regional crisis line about a youth, and an MRSS team can offer an in-person response. They're going to screen people into services, not out, and they're going to improve outcomes through wraparound principles. If a youth does end up in the emergency department or the new 23-hour crisis receiving centers, again, we want robust discharge home to reduce facility-based stabilization and hospital boarding. MRSS teams can respond to emergency departments and 23-hour facilities to help get the majority of these kids discharged home safely. New Jersey implemented MRSS, and they have closed 1 children's hospital and 8 detention centers. Next slide, please. This slide shows that Healthcare Authority contracted regional crisis lines and the MRSS teams on the left, and the 988 Suicide Lifeline on the right. 988 provides confidential phone support, and there's a dial pad options to connect to sub-network lifelines. Most calls to 988 are resolved over the phone statewide. Healthcare Authority and Department of Health are working on a cross-agency project to develop the 988 hubs and a tech platform to connect these two systems. That's future state. Next slide, please. Can you click that slide for me? Every one of these are a crisis appropriate for MRSS to respond to and address. Some of these are early symptoms of a diagnosable behavioral health disorder. Assessing a youth in person allows clinicians to understand how advanced a plan may or may not be, and you can assess for those environmental risks. Are there nearby bridges? Are there train tracks? Are there jumping access points? Do we have a youth sleeping on the 3rd floor and they have a window and we have a jumping risk? What are the anchor points in the home? I can give you an example of a very young kid under the age of 8 who was using a bicycle tube tire to wrap around their neck and anchor it to a doorknob. This family had a 2nd floor balcony, and they were completely unaware that they had a hanging risk at all. And so these teams are going to identify these risks, and they're going to help secure those items in the home. There's a one on here that says, hey, I can't get my kid to wake up to go to school. So I was supervising a clinician who was like having a no good, very bad day. And they said, oh, it's another parent. Why am I going out here? It's not my job to wake your kid up and send them to school. And I said, get out there and see what you got. You don't know what you've got till you get there. And sure enough, this kid was unconscious, unresponsive. We had to activate EMS, and this kid is fine today. So you never know what you have until you get there. And you need to assess the caregiver's strengths and needs also as part of that intervention, and the environment and those risks in the environment. Next slide, please. This is just a recap. To access MRSS teams, you're going to have to call your regional crisis line and discuss your needs, and then a team can come out and help you. So I can put a link in chat with all of our regional crisis line numbers. Next slide. Thank you very much for your time today and for the opportunity.
Thank you so much, Sherry. If you want to send me that link, I'll put it in the chat to everyone. I really appreciate you giving us this very thorough reminder of the MRSS model for responding to youth. And with that, we are a few minutes behind, but we can catch up here. It's now time to move to our panel discussion. Kashi, we're about 15 minutes past schedule, so I did check with our panelists, and it looks like everyone can stay until 3:30. So why don't we plan to go till 3:25, and that will give a little cushion.
Okay, perfect. And you feel free to jump in and cue me if I need to.
Okay, great.
So in the interest of time, I'm going to give very brief introductions for our panelists. Thank you to Sherry, to Diane, to Courtney for what you've spoken to, so that CRIS committee members have a sense of what our current state looks like and what best practices are. Committee members, you received more thorough introductions to the panelists or biographies of the panelists. So I'll be very brief and just share that we have 4 members for the panel today. Starlene Maharaj Lewis brings a variety of strengths, backgrounds, and insights, and is here among many things representing her lived experience. Both Diane Boyd and Sue Rash work at the Children's Crisis Outreach Response System, or CORS. You heard Diane Mays mention that in her presentation, that is one of the mobile response teams that youth connect to when they are experiencing a crisis in King County. And then Dr. Alicia Thompson is the clinical director and attending psychologist on the psychiatry and behavioral medicine unit here at Seattle Children's, sees a lot of kids in crisis and their families. So really grateful that you all are here today. I also want to recognize at the start of any panel that a panel has a finite number of people on it, and there are a variety of experiences that could really speak to what it's like to be a youth experiencing crisis, and that this is for people's voices, and there are a lot more voices that aren't at the table, critically including a youth voice. We did not have a youth who was comfortable speaking to the panel at this point in time, and really want to just name that is a missing voice in this conversation, and really worth the committee's continued consideration. With that, I will ask each of the panelists to introduce yourself and just let us know how you work with youth in crisis, or what your connection has been. And then I'm hoping we can do that question relatively quickly and get into the question of what are the unique needs of youth. So we'll start with introductions, and Starlene, I thought I would start with you if you don't mind me putting you on the spot, and then we'll go to Diane and Sue and finish with Alicia.
Oh, that's great. Thank you very much. My name is Starlene Maharaj Lewis. I use she, her pronouns, and let's see, I'm connected to youth. So I have both professional and lived experiences as it kind of pertains to youth and family engagement with behavioral health services. I myself, with my personal hat, have a child who has been diagnosed at a very young age from PTSD and ADHD. From that, a lot of the behaviors are explosive, and he is currently 14 years old, and we are still trying to navigate and get appropriate supports that can actually appropriate scaffold and help him and encourage him to be a successful member of, of the community. Thank you.
Thank you. Diane, do you want to go next?
Sure, thank you. Hello, I'm Diane Boyd, and I'm the clinical director at the YMCA, overseeing the Children's Crisis Outreach Response System for youth. And we also have what we call CORS YA, which is Crisis Outreach Response for young adults. And then we have a newer team over the last couple of years that is working with kids and families in crisis where their children have a developmental disability. And I've been with the Y for about 14 years. And yeah, I think that's me.
Thank you. Sue, go ahead.
I'm Sue Rash. I use she, her pronouns. I am a clinical supervisor with the CORS team at the Y. I've been with the Y for 20 years, with CORS for almost 17. I've been a therapist and supervisor working with kids and families in King County since 1995. So that's how I connect with youth and families.
Thank you. And Alicia, last but not least.
I'm Alicia Thompson. I'm the clinical director of the psychiatry and behavioral medicine unit at Seattle Children's. And I have been here for 5 years. And prior to this, I've spent over a decade working with youth in inpatient psychiatry units. And we really see youth who are experiencing the most severe and acute mental health crises on our inpatient unit. And so my interface with youth is immediately after a crisis to help stabilize the crisis and then connect them to the best resources moving forward and get them connected back to their community. And my hope is always that our length of stay on the inpatient unit is as short as possible so kids can get back to their community where they can get their care.
Thank you. You all bring a wealth of experience, both personally and professionally, to working with youth in crisis and those who love youth who are experiencing crisis. When you think about the unique needs of youth and transitional age youth experiencing a behavioral health crisis, what comes to mind for you? And we're specifically interested, although broadly interested in your thoughts, if you could speak to observations since the 988 line was implemented. So in the last couple of years specifically, what you're seeing in terms of unique needs with youth and transition age youth. I might actually reverse order here and give Diane and Sue an opportunity to start, and then Starlene, and then Alicia. So Diane and Sue.
Sue, do you want to go first?
Sure. I guess what I would say first is that we haven't really noticed many differences from 988 go through crisis connections, and necessarily always if it's a call that came from 988. So we have no things that have changed over the last few years, but not necessarily connected to 988. So I would just say that. Diane,
you cut out. Right here, what I heard you say was you haven't noticed a difference in terms of sort of how you're receiving kids who need support. I'm wondering if you could speak to some of the unique differences for youth and transitional age youth, particularly as compared to adults. Like, what is different about youth and young adults in crisis than about adults in crisis?
I'm going to turn my camera off and hope that helps with my not being choppy and well, specifically with youth, I think one of the things that's unique and different is that you run into the age of consent issue, which can be really tricky for lots of different reasons. We do have a large number since COVID of younger kids around 11, 12, coming with pretty significant suicidal ideation and other behaviors that previously were really more older kids coming in with. I'd say that's been a change in years. Also, younger kids psychosis that we see of hard. Am I speaking up a lot?
We heard you until that those were previously older kids, and then I heard something about psychosis, but I'm also it is a bad internet day, so maybe we'll give a
bad internet day.
Should we give you a moment to sort out internet things and ask Diane?
Yeah, I don't know. I've been having this problem all day, so Diane, maybe you could help me out here.
Yes. So as Sue was saying, I think a lot of kids that we're seeing earlier onsets of psychosis coming into course, and still a lot of ramifications from COVID, and a lot of anxiety, school issues, and things like that. With the young adults, the ones that CORS works with specifically are unstably housed and or at risk of losing their housing because of behavioral health issues. So substance use is one of the issues that we struggle a lot with, and finding appropriate housing resources, and shelters just not being equipped to manage a lot of the higher needs behavioral health. And, you have a lot of transitions of staff coming and going from these programs, which creates a lack of trust with other providers trying to come in and work with them. And the housing system itself being kind of challenging for those who don't work in housing to fully understand how to navigate it and help young people navigate it to find the right levels of care. And I think just in general, and Kashi, I think you can relate to this, is that there's a lot of these young people who have very serious, significant issues, kids with developmental disabilities, a lot of single parents, and they're trying to manage pretty aggressive behaviors at home, or the shelter staff trying to manage aggressive behavior in the shelters, and not a lot of in between type of placements for them. So they end up getting into the hospital, and then what happens after that, because the families are like, I'm not equipped to manage this, and there's just not a lot of appropriate resources to come into the home to support families in their homes. And there's no respite options. Some of these families just need a break, and it shouldn't have to be a hospital for them to get a break. And so I'll quit talking for a minute and see if you have follow-up questions.
Well, I saw Alicia nodding, and Starlene, I want to hear your perspective here. But Diane, I think you made such a good point that in reality, we use the word crisis, and that refers actually to a lot of different things, right? The initial crisis that makes someone pick up the phone is different, but is still a crisis from the crisis that sustains if you don't get the resources you need to support your child, right? Or if you don't have support in your home, or the shelter can't manage their behavior. And so, we have one word to describe such a range of challenges that families and kids are facing. Starlene, when you think about the unique needs of youth and transition age youth in crisis, what comes to mind for you, especially as different from adults?
This is very serendipitous, because I can also provide a relevant and current example speaking to this, to answer the specific question on unique needs of youth. So one, I mentioned my child is 14, and so therefore is at that age of autonomy when it comes to, accessing behavioral health services. And so my child has been in therapy since a very young age, and therapists, at different varying degrees of success, has been able to provide that scaffolding needed. In our situation, my child does need constant you cannot remove that scaffolding, right? It's not a matter of using the tools and then my child, I don't know if all children are like this. I do know that my specific child needs that scaffolding. It's not even just been absorbed by myself. It's been absorbed by teachers as well, educators, over the years. So speaking about the specific instance that comes to mind right now, which furthers some of the challenges in being able to access these services, is the actual 988 line. I had the opportunity to engage with 988 this past weekend because of explosive and aggressive behavior from my son while I was trying to work. I work remotely. And it got to the point where I needed respite. I had learned about a respite center. If you look on the website, they talk about it. They talk about the availability, the number of beds, and how to access those services, either through making an appointment or walk-in. I also then called. I'm getting ahead of myself though. So I did call the place as well. And then the same thing, they mentioned that they had beds available. There was, options to either make an appointment, leave your phone number, we'll call you back, because it was a voicemail, or walk in. We decided to walk in. The receptionist said she'd never heard of the program. Never, even to the point where I was showing her on my phone the website and the phone number. And she said, yeah, that's my phone number, but there's no message on my phone coming from you. And the program doesn't exist. In fact, she even said she would call the doctor. I'm assuming a clinician. I don't know who the doctor was. Spoke to someone on the phone for a few minutes and said, yeah, this program, we've never heard of this before. The address was correct as well if you do a Google search. Taking a step back, how it all started was because I was working And while my child was acting very aggressively, and I made the choice, either to step away from my workspace or remain. It was meetings I needed to attend and I was leading, so therefore I chose to stay. During that time, though, I was multitasking and chatting with 988. So I engaged with 988 over the chat. The response was, they kept coming back. First, you need to go through the demographic questions, right? And sort of funnel into the correct area. Finally got with an agent on the chat who kept asking me if my child had suicidal ideation. And so I said, I don't, from my perspective, I don't think so. And that's all they ever asked me. And said, we can't help you if your child does not have suicidal ideation. So I thought, oh, okay, thanks. And so then I thought I will call them. My meeting was over and I thought I will call 988 and solicit services because I really need them at this point. I need some kind of help before doing my own Google search. And so when I spoke with the agent, the 988 agent, I was referred to Washington 211. That was the only referral they could give me, was Washington 211. And so that was a dead end as well. And so with the unique challenges, it's been a long few days, starting with, just this past Friday of, being able to de-escalate the situation myself with I do wear that profession. I work in systems. I'm not a therapist, right? I'm not a clinician, but through the years, learning the tools for being engaged with, other therapists and just being in systems level work, just trying to de-escalate to the point where there was that inroad. In theory, at that time, I thought there was an inroad to drop my child off at the 23-hour, 59-minute care center, respite center, and de-escalated that my son was willing to get in the car and go to the respite center. And then I shared what happened after that. I called a third time to the crisis line this is DCR. Right, so the crisis response unit, call them, and their suggestion or recommendation to me was to take him to emergency. And that's just not gonna, even short term, that's not gonna, that just wasn't gonna do anything. That wasn't what was needed at that time to resolve, the immediate crisis situation, so.
Darlene, thank you for being here to share this perspective. I think what you've just shared is so critical, and I have extra appreciation for the fact that you're doing it while it's still so fresh. The Friday that you cited was so recent, and I appreciate what you're reflecting back for us about the reality that you and your family have experienced, that you could not get what you needed from the system right now as it is, and how do we do something better? So, Alicia, I think this might actually dovetail into some of the things you see, so I'll turn it to you.
Yeah, Darlene, thank you so much for sharing your experience. It's a perfect example of things that I see every day on my inpatient unit. And I think one of the things that I heard other folks talk about is about what a crisis is. What is crisis? How do we define that? And I think one of my concerns about 988 is what Starlene already talked about, is that we're only defining crisis as suicidal ideation. And the reality for youth is that youth who are experiencing crisis looks a lot of different ways. And one of the groups of families and of youth that I see that I don't think are served well by 988 at the moment are youth who are experiencing a crisis that results in physical aggression or elopement or running away behavior. And I can't actually say this better than what Starlene already did say. So I'm going to repeat basically what she said in the aggregate. But often what I hear from caregivers is that they struggle in the moment with how to safely manage their child's behavior, especially if they're home alone with their child, if they're the only person, and how do they make a decision between getting in front of their child who has a weapon that they have made out of something in the house, between letting a child out of the house in a way that could lead to eloping, and then wildly unsafe things that happen when kids run away, right? How did they make that decision, and what do they do in that moment? And what I hear time and time again from caregivers is that they really need somebody to come in the moment to help de-escalate the situation, that they can't be the only one. And the reality is that the only place that we do have, and Starlene, this is your example, perfectly teed me up to say this, is to say, oh, we need to take this youth to the emergency department. And what I, as somebody who works in the inpatient unit, receiving kids from the emergency department, I have a lot of concern about that, because I actually don't think that that's the best way to provide care for youth. It can be traumatic. It can often, by the time you actually get to the emergency department, the crisis is resolved. And so youth might not even meet criteria for inpatient admission. And so then it's like, okay, well, just go on back home with a crisis prevention plan that we've made for you, but without anything really tangibly changing. And so my really large concern is how we support youth who are experiencing, severe emotion dysregulation that results in eloping, aggressive behavior, that kind of thing, and their caregivers for how to manage those behaviors. I think that as a system, we have some good evidence-based practice for how to manage suicidality, and are continuing to build out a better continuum of mental health care for youth with suicidal ideation. But I don't think that we're meeting the need when it comes to youth with aggressive behavior. We have a long way to go to kind of catch up to where kids who are experiencing suicidal ideation are at, in terms of what services we can offer, both in moments of crisis, but also to prevent long-term issues and to prevent future crises.
I really appreciate that. And I think that has been resonant from what others have shared with me too. And what I will say quickly and then turn to the next question is, I reached out to one of the community-based providers who also has youth mobile crisis teams and provides community-based behavioral health services, and asked some questions about how things are going from their viewpoint. And they shared a very similar experience, that parents have said they had to call 3 or 4 or 5 times to the 988 crisis line to get all the way connected to the mobile response team, and that it leaves a real gap, and there's still a lot of process to be worked out to ensure that that one phone call really does connect you to someone who can come support where you are. And I think Sherry Wiley did a really beautiful job of explaining why mobile response is the least restrictive intervention for youth, right? And their families, or their chosen families. Given that you as panelists are speaking to the CRIS Committee, which is the group advising on how Washington should build our crisis response system in conjunction with 988, how do we need to approach the crisis response system to improve it to support youth specifically? So taking what you just shared about unique needs, what do you want to see the crisis system do for youth? And maybe we'll go reverse order. Alicia, do you want to start? And then I'll go to Starlene, and then Diane and Sue.
Sure, happy to. I think you've already kind of said it, Kashi. I would hope that when someone calls 988, they're connected to the right resource immediately, that they don't have to call multiple times, that they can be connected to the mobile crisis response team that is going to come and help support them in that moment. I think that was my hope for 988, that it's sort of this one-stop shop. You can remember the number easily and then be able to be connected pretty quickly to the right resource. And so that's what I'm seeing is missing right now, and I think would make a huge impact for youth and for their caregivers.
Thank you. I'm managing video and audio because I'm also having an internet day. So sorry if you see me looking down. Starlene, what comes to mind for you in terms of improvements that could be made in the crisis response system for youth?
So interesting that's such a great question too, because based on the events that occurred over this past week, from Friday over the past weekend, my first thought during that time, after calling 3 times and just getting, coming up with a dead end and a dead end and a dead end, my first thought was, I need scripted language. I need to know the correct, it's almost like we need the correct language. And again, right, I kind of have, I have a foot in both roles. But on that, there's no pun intended, though. I'm not making a joke here. It's just, it's right, because there is a language that's used, and there's certain, coded language that's used, or framing or acronyms or whatever it is, where we, when it comes to behavioral health systems of care, we understand a certain vocabulary that a lot of people don't have. And even myself, calling 3 times, and still, not once did anyone refer me to any kind of mobile response team anywhere of any kind, right? Or even someone to even talked to over the phone, right? I gave the examples of where I was led, which was just dead ends, basically. So one, it's that scripted language, or two, Alicia spoke about that very well, where it's similar to 911, where you're directed, you're triaged immediately rather than going through all these different questions. I feel like that's what's really needed, where instead of going and asking certain questions, where if we're not posing the questions in the right way, or answering or responding in the correct way, based on a person's, the person on the other line, their perceptions on how, how the parent or caregiver should be responding, and therefore I'll funnel them this way. It should be much more simple. It needs to be simplified. Right, or plain talked, or I don't know, maybe we need little postcards of scripted language that it's funny, but it's not like, do we need scripted language where, okay, I'm going to call 988 and this is, this is a sort of like, I'm going to triage.
Well, and I think what you just said is so powerful, because when we were talking about the vision for 988 and the crisis system, part of that was that an administrative burden on understanding how to navigate the system wouldn't be on parents, right? The goal is that you don't need scripted language. And yet what you're sharing with us is the reality that was the experience you had, right? That you walked away feeling like, I wish someone had told me what words to say to get what I needed, because I didn't get what I needed. And I think that's a really important reflection for this committee to hear, that we are not meeting the vision we set yet, and we have work we can do to get there. So thank you again. Diane and Sue, you're both back, internet success. Either one of you, please chime in on what you think could be improved in our crisis system for you.
I am doing what you are doing, Kashi. I have my phone on for audio. Hopefully you can hear me. One of the things that I would want to say is more use of peers across the board. So we in CORS, we use parent partners and youth peers, but I think that the use of parent partners specifically in the crisis response to support the parents can be increased. That would be one of my questions.
I love that idea, Diane. I'll let you go in just a second here. I will just validate that is, having been a former inpatient psych staffer, a former emergency department mental health employee, that was something I heard repeatedly from parents, was how lonely it was to navigate the mental health system for your child, or to not know if others even had a similar experience, and being able to, this was long before we had robust parent partners or parent peers embedded in teams and in systems, and families were really wanting that and needing that. So I really appreciate that. Diane, thanks for letting me jump in front of you.
Sure. I guess I've been thinking a lot about, that we all want to reduce the use of law enforcement in helping people with behavioral health crises. But we also have to make sure that there's protocols and things in place that support the youth, the family, and the person going out to address the crisis, so that everybody is safe. And so I've been trying to think about what that looks like, but I guess one thing would be making sure that 988 and Crisis Connections are thoroughly vetting the call and what's happening in the situation, so that the staff feel like they're walking in well informed to what potential safety issues are. Yeah, I think that's.
And I think that on that point, when we talk with, at least when I worked on the inpatient unit, when we talked with staff about this in the hospital setting, part of what we shared was the value of calling when it is an early crisis. Again, this is the flaw in our language, right? Or we only have one word for crisis, but you can call much earlier before there's safety risks in place. And that gives people so much more time to engage safely, to bring other tools and interventions to that table, and prevent the need perhaps for a more restrictive response, or a harsher team to have to show up, for lack of a better term. And so MRSS or mobile response, or things that really do meet people where they are as they define their crisis, might even serve some of that need to prevent us from having to send out teams when it becomes a real safety issue because we didn't have anything prior to that, right? And I think that's sort of where we are currently with where we send youth, because we don't really have respite centers. 23, there are maybe one 23-hour crisis center for youth in the state. And so they're going to the most restrictive setting, which is the emergency department. We did promise to take questions from the CRIS committee. So Jamie, I saw Jamie's note in the chat that if you have questions to start sending them to Jamie, she'll send them to me and I will ask them aloud. So as people start sending their questions for you all, what is one key takeaway you want this committee to know about youth and transitional age youth in crisis? And I'll stick with my reverse order theme and start with Diane again.
Shoot. Well, I think the crisis centers are going to be great when they get up and running, but I think also continuing to look at other things that are gaps in the system that are needed around supporting families and trying to build up a respite system outside of the crisis centers. But, you know, DDA has respite for families, but there's huge long waiting lists and things to even qualify for it. So I think trying to look at where some additional system supports could be put in place to fill those gaps to help families get some breathing room and breaks so they're not feeling like they're in crisis all the time.
Diane, do you want to explain for folks just a little bit about what DDA is? I don't know that that's an acronym that's familiar to everyone. Just
Department of Developmental Disabilities.
Thank you. Sue, what comes to mind for you, a key takeaway about youth and transitional age youth in crisis?
Well, I was going to say what Diane said. I think that there is a lack of breadth in terms of the types of services in a continuum that youth can access depending on their insurance needs. It seems to be they're getting outpatient or they're going to the inpatient unit, to the emergency room and then the PBMU. And not every kid needs to be in the PBMU, right? There are kids who do, but we need a broader depth of options for kids. And sometimes if the families have the resources, they can send them someplace private, but that's not the case for everyone, and there needs to be more options.
And I think, Sue, to your point, maybe to make the implicit explicit for the conversation we've been having the whole panel, is that the crisis system for youth in many ways is the front door to a system of behavioral health care or substance use care. And without a robust continuum to connect kids and families to the crisis continuum, there's a struggle there, right? And I don't know if I have perfect language for that, but if you walk through a front door and the rest of the house isn't built, what do you do? And how helpful can that front door be if it can't lead you anywhere? And that's sort of hyperbolic. Yeah. Having spent a lot of time navigating these systems and having talked to families who have tried to navigate them themselves, it doesn't feel hyperbolic. It feels like there's really not much on the other side of the door, depending on the issue that you're facing. So I don't know if that makes you want to add anything, but.
Oh, it just means you just keep coming through that same front door and you get the short-term crisis support, and then you go back with just a little bit better, but not with enough long-term support. And then you come back because there's no limit to the number of times you can, get crisis support. But wouldn't it be great if they could get enough help that they don't need crisis support anymore?
Mm-hmm. And then at some point, if you've come back to the short-term crisis supports multiple times, that crisis, you don't stay the same through that whole process, right? You come back further in crisis and further frustrated because it didn't work and you didn't get the support that you needed. And at some point, you probably do need the emergency department or an inpatient unit, but it feels preventable in that way.
Right. Yep.
Thank you. Starlene, what comes to mind for you in terms of a key takeaway about youth and transition age youth?
think you all actually already touched upon it, because that's my biggest takeaway. I was thinking, again, referring to, my experiences, my recent experiences, just being able to access services, it was such a challenge. And in my mind, that takeaway, so I think about now my 14-year-old who is an eloper, aggressive behavior, has damaged property, in the home, has explosive behavior. I mentioned that before. And I mean, even with the most recent instance, had brandished a weapon at me. So, right. And so it's escalating. It's and each and every time, not only if I'm calling, but then I make, I'm like, because he is involved in that side of behavioral health. And so is someone who's very comfortable, for example, working with therapists, the times has been engaged. But it makes me think about, should he be in crisis and start calling 988 himself and coming upon these barriers himself? It'll promote that sense of distrust or further distrust with the system, and he's less likely to engage. Right. Again, speaking of my child's experiences, that sense of distrust, if trying to even get to access services or even a follow-up, because that was one thing I was surprised. I was at a recent webinar or some kind of presentation anyway about the services, and it was talking about follow-up. And so that, once we provide these services, we're going to reach out and see how you're doing. And so I was never offered that with me calling. And so again, getting into the mind of someone who's a teenager, there's, okay, we're going to give you these resources, call this other number. So it's almost like getting passed around, first of all, right? That further builds that sort of sense of mistrust and distrust in the system. But then also there's no follow-up. They're not going to reconnect with you. Okay, bye-bye, see you later. We're going to hang up now. Good luck. Or whatever that complimentary and closing looks like. So that's my takeaway.
Thank you.
Mm-hmm.
Thank you for saying that and for naming the distrust that can perpetuate with systems. I think we've heard that as a resounding theme throughout our conversations in the CRIS committee about wanting this to be a system that builds trust rather than breaks trust, because I think trust in these systems doesn't always start particularly high, and with good reason. Alicia, what would you add? What's your key takeaways for youth?
Yeah, I think I'm just probably going to restate a lot that's already been said. I think the first thing that comes to mind is that youth are part of systems. We absolutely have to support caregivers. And the first way to support caregivers, in my mind, is make it as easy as possible to access what they need to access. We shouldn't have people have to be experts in how to navigate this system in order to get connected to the right care in a timely way. Also that crisis care can't just be immediately after a crisis, because otherwise we're going to continue to sort of repeat this pattern of we respond in the moment, but then we don't address things long term, and we'll just continue to have more and more crises. So we also need to think about prevention and really making sure we have a robust continuum of care that people can actually access. So that way we are continuing to help support youth to prevent future crises or potential crises at all. And then also that crisis has multiple definitions. We can't just think about this as a crisis related to suicidal ideation. There's so many ways that youth have crises. And so we have to consider all the potential ways that youth are having crises and be able to support them and their caregivers whenever those might occur. And that includes considering developmental abilities for youth, right? And I think one of the things that often is a concern for me, and then also for the caregivers of youth that we see a lot of kids who look like adults and developmentally are pretty young, right? Because of having an autism spectrum disorder or a severe intellectual disability. And we need to have a clear way to make sure that people who are responding know what's happening. So that way, when they respond, they can respond appropriately to be able to safely de-escalate a crisis. And then I think lastly, we have in our current system, youth need to fail out of different systems in order to be able to reach the next step. And if caregivers, if youth, if Their clinicians who are providing them care are seeing the writing on the wall that this isn't working. We need to be able to access the next level of care more quickly rather than having to try something that we all know isn't going to work, because I think then we're kind of setting everybody up to have another crisis.
Alicia, just because I don't know if this is the same case in the adult system, would you explain a little more about the issue of needing to fail out of specific things or fail up essentially?
Yeah,
This might be the
so
case in the adult system, but I actually don't know.
yeah, so I don't know about the adult system either, because all I've done for my whole career is work with children and adolescents. So hopefully folks who work in that system can help us understand this a little better. But in the youth system, if we need to get kids connected to children's long-term inpatient, as one example, or residential treatment, we have to show that we've tried all of the intensive outpatient programs that exist, like WISE services is one example, and that it hasn't worked in order for them to meet criteria to be able to access those systems. And in some cases, and we've got youth now on our unit who we can't discharge for more than a couple of days. They can't even get to the service to show that they failed out of it because they can't manage at home for more than a few days. And so it's really clear to us that they should have residential treatment, but we have to kind of jump through these hoops in order to get them there. And so I would love to be able to connect kids to the right level of treatment when they need it, rather than having to go through all the red tape.
Thank you. I really appreciate that explanation. And in case that is a situation that's unique to the youth world as opposed to the adult world, really wanted CRIS committee members to have that context that youth are sometimes required to try these things, even if we know they're not going to be particularly effective. One question from CRIS committee members. We heard about youth peers. Does that include supporting the siblings of youth peers, or who supports siblings or other family members? And I think I'll put that question to those who work on and support mobile teams. So Diane or Sue, what kinds of supports exist for the siblings of a youth struggling?
We consider ourselves to be working with the whole family as much as possible. And as many people in the family are interested and willing, and however they define their family. So we actually were in one of our triages today. We're just talking about a family where there's one youth in the family who's the identified client. They were the one who had the crisis that came through. But we're actually doing a lot more work with their sisters for some reason, and I don't remember the details, and not that I would share them anyway, but so that's just an example. We end up doing a lot with lots of members of the family, and I don't know if that's true for other crisis teams around the state, but that's what we do in CORS.
Thank you. And I have heard parent advocates in other forums use the refrain that a child in crisis is a family in crisis, and that sometimes the one child who has the one presenting crisis may not actually end up being the child who is most in need of intervention. That intervention might be necessary somewhere else in the family system, which could, to your point, be a sibling or a peer in the family.
Yeah.
There was a great question from a CRIS committee member about what does a safe place to be look like? So when we talk about 988 or the crisis system, there's got these three pillars, right? Someone to call, someone to respond, and a safe place to be. And real shout out to Sherry Wiley here from HCA, as Bipasha noted in the chat, really reframing somewhere to go as for youth, a safe place to be. So what does that look like for youth, and what services would be available in that safe place to be? Happy to open it up to anybody who would like to answer it.
I'll take a stab, and then Sue, if you want to add on. I think for us, it means if we can work with the young person and the family and keep them at home with supports, that's ideally great. But also looking at natural supports. So are there grandparents or aunts or uncles or somebody that they can spend some time with for a few days, or even, they might identify a friend from school and the parents agree that it's okay for them to go spend a couple days at a friend's house. So really trying to keep them in the community with friends, family, as first options before looking at some other type of next level option. Sue, did you want to answer additionally?
While we're looking at these crisis centers in King County opening up, thinking about child and youth friendly spaces. So even there's supposed to be a one that's specific for kids, but I think kids could even show up at one of the other crisis centers, and there needs to be staff that are child mental health specialists or youth peers, or people who are trained to be working with youth, and spaces that are comfortable and feel safe for youth. I know many of us have had that experience of being in a community mental health center with youth and adults in the waiting room, and what that can feel like for a young kid. That can feel scary sometimes. So spaces that feel comfortable and safe for kids and their families when they're in crisis.
Darlene or Alicia, other things come to mind for you about what this safe place to be looks like?
I'm happy to share. This is Starlene. So when I think about safe spaces and within the context of crisis situations or emergent crisis situations, depending on what definition you're going with, I reframe it in my mind, because I think about the situation itself where both parties, or multiple parties, somebody in that situation is dysregulated, at least one, maybe both, usually both at that point, right? I'm speaking from personal experience here. So both are dysregulated, both are activated. So a safe space is going to be somewhere where you can what's the word I'm thinking of? De-escalate, right? And sometimes that means, in my situation, that does mean that we cannot be in the same house together. Going to a bedroom does not work. Sending my child to his bedroom, he doesn't feel like it's a safe space, so it's not going to work. And so it's almost that reframing of it's more that situational awareness in the first place before even identifying, the specifics of what safe space looks like. Does that make sense? Right? Is identifying, whether it be in a safety plan, but then in a crisis situation, the safety plan's fallen apart. And so what happens at that point, right? Being able to have some form of, at that point, I think professional coming in and acting as mediator, or supporter, pick a word, right? to find what that safe space might look like in that moment, because if nothing else, it's now going to take away the focus of the actual crisis situation, and people can start working on just getting back to sense of self and self-regulation.
I think you just named something really important, and what we've been talking about is, how do we make sure existing spaces where youth and families feel like the safe places they can be, right? What other services and supports can be there, and recognize that for some kids and for some families and for some kids and youth who don't have families who feel safe or confident, or who they don't have good interpersonal relationships, where are there places they can go? There are going to be families who the safe place to be is not remaining in the home environment right now. It is having somewhere different. And so how do we have different places where families can be that feel safe? Alicia, I want to make sure you get an opportunity to add something if you wanted to.
Yeah, I think I don't have anything wildly unique to add. I think already Diane and Sue and Starlene spoke wonderfully about things that are needed. And I do think we need more respite options that are easily accessible, that are not just if you have DDA or DCYF engaged in your care. I think those are currently the only two ways that I know of to really easily access respite. And most of the kids that we serve actually are not served by DDA or DCYF. And so then they don't have the ability to access those things. And so if we could have some way to have a respite system, I think that would be great. And to your point earlier, some families do have aunties or uncles or grandparents or family friends that live nearby that are an option for that. And most of the families that come to our unit are at a point where those other folks have felt like, oh, we also can't manage this, so we're going to say no now. Or the family is living far away or has had lots of trauma and stress within their family system, and that it's not safe to send them to other people in the family. And so we need to have other options other than just within a family system. We need to make sure that we've got options for folks.
Thank you. I think that's a really important note, that there are some families where they have lots of natural supports and some youth who feel really connected to their families and have lots of natural supports. And that is not going to be the case for all of the kids and families in this state. And so we will need spaces, safe places to be for youth who aren't particularly connected to their family or whose caregivers don't have a lot of natural supports in their family or their friends. And I know that we are running close to time, so if folks have to drop, totally understand. 2 more questions from the CRIS committee that have come in. One, I don't know that this panel will be the right audience for this, but I want to name it as a really important question, especially given the lived experience story we heard earlier, which is, how do we ensure those places are actually safe? And not only safe, but culturally responsive and able to provide the care that youth and parents and those in crisis are asking for. If someone wants to take make an answer to that, I would love to hear it. I think it's important to name, even if it's just a hypothetical, so we can be asking the CRIS committee to think about policy and oversight and accountability so that the care continuum actually is safe and provides good care for people in crisis. I don't know if there's people who want to answer that question. I'll give you a minute to think about it. Okay, the other question I wanted to be sure to ask was, given that we don't have a youth voice on this panel, how can we make this space particularly more comfortable and accessible for youth? So from your all perspective, as those who work with youth, yes, Starlene, you get to go first. I saw your hand go right up. So what could we do to welcome youth voice, please?
So, here's the deal. When working with adolescents, right? And we've all worked with adolescents, and you know, and some of us get to do both, and some of us just have the one. But so one thing I find with adolescents, it goes back to that adage or the model of meeting people where they're at. And so answering a question like that is really going to ask them, what? Oh gosh, now I lost my train of thought. Can you repeat the question, please?
Yes.
I know it starts with them.
Space more comfortable and accessible for youth. We should ask them.
Engaging, right? And that's the whole thing, right? And so engaging youth a lot, and this is just my personal reflections on adolescents, whether it be personally, you know, I'm also an auntie, professionally leading youth groups. Is I find that adolescents, they either don't say anything or they don't stop, especially when they're comfortable with you, which is great. And they communicate in so many different ways. Like I've had conversations with my niece over social media platform where I'm trying to go to bed and she's just so engaged. So, and it's wonderful. And I love that age group. But one thing I found really useful in being able to address multiple styles of building trust and communication is key informant interviews, that one-to-one space. And offer and asking them what would work for them. Does it mean that, you know, being recorded in some way, shape, or form, submitting artwork, right? There's multiple ways of communicating. I could get on a soapbox for that one because there is just so many different ways. You know, having a small group session that's only led by a facilitator, a note taker, and the youth, being absolutely transparent of what's going on and what, you know, and also offering multiple sessions where the first session is more like an introduction session and getting to know you all, right? And then the second going more into the questions.
I love that. And I was typing furiously, which is why I had a hard time getting off mute. Those examples are brilliant. And I saw you light up at that question. So thank you for jumping right in. Other thoughts on how this could be a space that we hear directly from youth?
I think in general, I would echo what Starlene said. We really just need to meet them where they're at, right? And make it easy for them to be able to contribute. Find out where are they at, so that way we can meet them there and ask them questions there, both in terms of like the psychological space of how they're feeling about it, but also physically, where are they congregating, where are the places that we've got folks who will be able to give an opinion, because if we make it hard and require people to come to us, I think it's going to be a barrier.
And I think that that's such a good point, psychologically and physically, and from a timing perspective. Like, I'm not a parent, so I don't know if kids are out of school yet, but if they're not, they're probably in school right now. This is an hour at which they are in school. And so that it would pose a real challenge, because we want you to be in school, and we also want you to have an opportunity to live, to share your voice of lived experience in places where decisions are being made or recommendations are being made about how we should improve systems. We've got just a couple minutes. I don't see any other questions from CRIS committee members. So Sue, yes, you're right. Hi, Sue.
I see Puck has been raising their hand.
Oh, thank you. I can't see.
Sorry, I didn't see that.
Well, hi, I'm Puck. I'm one of the lived experience folks on the CRIS, and I heard the question about asking youth, and I heard the question about safe places to go. And in the examples I heard of like what different supports look like, it just made me think about individualized supports. It made me think about that moment that Leah's kid had running, getting checked in and like signing all the papers. And when you're like kind of dissociating at this point because you've been in crisis so long and you're not paying attention. And I think that like instead of that, we could like work on getting people stabilized and then have a conversation with them about what their care might actually look like to be successful for them, and how we would know that they were doing okay at the place that they were at, etc. I feel like there are probably some programs that do this kind of, you know, like we talk about person-centered planning, but I do think that we get really tied to our rubrics, and maybe one way is to try to ask the youth to tell us what's going well, but not here, not in this space. Don't make them come here.
Thank you, Puck. Sue, thank you for noticing Puck's hand. Puck, I hope you didn't have your hand up terribly long. I really appreciate your voice here, and recognizing that individualized supports make a big difference, and asking them not only what's going wrong, but I really appreciated your question about what's going well. I think we often have a tendency in system improvement work to ask what isn't working, and we forget to ask about strengths or things we want to celebrate. And so what do youth find successful about the current system would be really interesting too. And are the spaces you're in currently, do they feel safe, and how could we make them safer? Panelists, thank you so much for your time today and for sharing your insights and expertise and your lived experience. Again, these are 4 voices with a lot of brilliance and wisdom, and they are 4 voices. And to quote someone who trained me when I worked on the inpatient unit, if you've met one kid with autism, you've met one kid with autism. And so if you are hearing one crisis perspective, you're hearing one crisis perspective. And there are many more voices who could have been on this panel. And so I encourage the CRIS committee to continue leaning in and learning about the unique needs of youth, and specifically transition-aged youth who are experiencing crisis, the needs of those who love them and support them and are going to interface with these systems on their behalf, so that we can build something in Washington that really does meet people where they are and not leave them there. So thank you so much to all of you for taking the time to share with this committee. Jamie, I think I turn it back to you.
I just want to echo everyone. That was a wonderful panel discussion. Thank you so much for your contributions, and a huge thank you to Kashi for doing the planning with us on this and for moderating today. That was fantastic. I do want to give folks a quick stretch break. Like I said, we were running a little bit behind time, but we only have one person signed up for public comment today, so I can give you a quick stretch break. If everyone wants to take 5 minutes and be back on camera, I have 3:23 on my clock. So if everyone can be back on camera at 3:28, we'll do some group processing as a CRIS. It's just going to be scratching the surface. I know we have lots more to talk about, but we'll make sure to reserve time when we get back together in July. And then we have a couple of final agenda items and then move into public comment. So see you back on camera. We'll say 3:28. See you soon. Welcome back. Let's see here. All right, so CRIS members, I do want to spend a little time just processing what we heard from the panel discussion. I know that we don't have a lot of time, certainly not enough to do what we just learned enough justice. So we will also commit to reserving some time to follow up when we get together in July. But I do want to spend a few minutes hearing from you, in particular, what your initial reflections are on what you heard today. I see Bipasha. Bipasha, why don't you kick us off?
Yeah, that was a really good panel. Thank you to the panelists and for Kashi for moderating it. I do have to say, I'm speaking from obviously my experiences being a person who answers the calls on the crisis line, that everything I heard resonated very deeply with me. And I feel like there's a big gap, like Sherry talked about, for example, Sherry, the things that you put up, like my kid can't wake up, so they're not going to school, they're suspended from school, they're moody and isolating. And I feel that right now, those are not really qualifying for an MRSS response. That's my experience of the system. And I feel like 988 is sort of somewhat of a gatekeeper to the next level access. And I think again, I say everything I say without any blame. I think there is a bit of a scarcity mentality in the system right now, where maybe what MRSS is offering is not what is being screened for. And I think there's a deep need for education between what Sherry is saying and what is being screened for. And I heard that, I mean, everything the panelists said, I was like, I've heard this story after story from families, and they will call with what seems like, oh, they're not in crisis. When we heard that you have to be in some kind of suicidal or high crisis to be able to get into the MRSS, just without giving any specifications. A few weeks back, youth having a lot of different behavioral patterns, including cutting on their palm, but also eating lunch and also yelling at parents. The behavior profile is very complex. And I think Sherry, or I don't know who said it, but it can't just be a suicidal crisis. And I feel although MRSS is communicating it doesn't have to be, that's not what's being screened into. I'm to be fair, it's not just suicidal crisis. There are other things that are being screened, but there are some lower level stuff that I keep hearing, well, this is not really a mental health issue. And I am begging whoever needs to make that connection between what MRSS is offering right now and to the people who are saying, yes, we will engage MRSS for this family. I think we really need that, connecting those dots right now. Thanks.
So Bipasha, I'm hearing you say, and it sounds like you heard reinforcement of this, of your own experience with what you heard on the panel, like from Starlene's story and so on, that there is a disconnect between what MRSS, what we're saying MRSS is for, and what's being communicated out, and what is actually being screened at the call centers. That's fascinating. Okay, thank you. Other reflections from the CRIS Committee? Kristen.
Yeah, similar to when we've talked about adult services, that disconnect between knowledge of what actually exists and the people who are making recommendations. There's no easy way for people taking calls to know where to refer to, because it seems like some things that have websites even, or that we have phone numbers for, don't necessarily actually exist anymore, and we don't know how long that's been. So finding ways to make those connections between the programs that exist at the various levels of the crisis system, so that the people making that initial contact, whether that's through 988 or MRSS or whoever is going to be trying to help a youth or a family get something they need, knows what services are actually available. Otherwise, it's hard to make a good referral.
Yeah, Kristen, I think that was so much of what Starlene's story was about today, about her experience on Friday. So, and it sounds like folks at the call center have that experience on the call center side. So thank you for raising that. Alicia.
Hello, my name is Alicia Morales, and I am in the EMS agency with the CRIS program, and I oversee an alternative response program. And I think something that I heard that I from my position, I feel like I bring up every time is the important connection between the 911 system and the 988 system that needs to be happening, because a lot of the outcome was we're unsure, or this level of care that you might need, we don't know how to connect you to, so take your youth to the emergency department. And the way that people are getting to the emergency department is through activation and engagement with 911. And so if there are teams that are not necessarily, there are teams that are embedded within law enforcement agencies, and I know there are more teams that are starting to develop that are not necessarily embedded within law enforcement agencies. However, they are within the 911 system. How do we ensure that there's collaboration there? Because if somebody's calling 911 and the response is not fire, a medical need, or a law enforcement need, and there are teams that exist that can support, how are we ensuring that those teams are getting connected to those people outside of just needing a person to call 988 if that connection currently doesn't exist. So like our team is available and we respond, but currently the connection to 988 doesn't exist, but we do respond to 911 calls. And so how are we ensuring that as those teams continue to develop and we develop more ways for connection, that we're always connecting the 988 911 bridge and services? Thank you.
Alicia, you're making a really interesting point, and I've heard you bring this up, as you said, in other discussions, but you know, some of what we've talked about today is the need for a service that isn't there, and what you're raising is there's a service that's there, but the connection isn't happening. We're not, if I'm hearing you correctly, that relationship between 988 and 911 and the opportunity to connect with a service like the one that you co-manage, that linkage isn't always there. Am I hearing that correctly?
Yes, and it's very new. So building behavioral health response within the 911 system is a very new book of business and body of work that's happening. And so just building connection and understanding of what does this look like within a system that already exists. 911 has existed for a long time, and it's slowly over time built the law enforcement response, and it's then built the fire response, and then the EMS response, because there was a community need for those types of response. And now we're seeing a community need for behavioral health. People are calling 911, especially community members that don't have any connection to a person that they might see in crisis. So they don't know somebody, but they have concern. People, from my perspective, they're not calling 988. Also from the perspective of my counterpart, we're seeing that people are calling 911 and saying, this person looks like they're in crisis, or they need some help, and we don't know who to call except for calling 911. So having programs that are embedded within the 911 systems that can respond builds more opportunity for people to get resources and care and support that is beneficial outside of going to jail or the emergency department, where those services might be offered. However, those people are also that's not their primary function. So how do we bring it back to the primary function of each service?
Thanks, Alicia. Leah, I saw your hand up. Did you want to speak?
Yeah, sorry, my grandson had come right behind me. He's 1.5. He felt the need to come in here. So I was just wanting to make sure that I had spoke with somebody, I believe she was Department of Health. Again, because of sharing my son's story, I have a lot of people that have been contacting me to hear it or try to find a resolution to it. But something that she shared with me was maybe we need to, with my son's situation of him being referred to a facility that was unlicensed, that we are making sure that there maybe it could be a WAC, something in place to our detox facilities to make sure that whoever they refer to are licensed or they have the type of training that is necessary. Cultural competency training at the least.
Leah, you are, I think, speaking this committee's language. That has been top of mind for this CRIS committee, and many members echo what you said about cultural competency and the importance of learning that. And I think your story today emphasized why that's so important.
Okay, thank you. I just need to make sure I said that, shared
I'm
it.
so glad you did. Thank you for staying for the whole meeting.
Of course.
Dr. Snowden.
Thank you. I echo what Pasha said, that there's a huge gap between our vision for how the system is supposed to work and the actual experience of people in the system. And it makes me think that the notion of simply counting the widgets, how many of these things we create, won't get us to where we really need to be. And a lot of the emphasis that we've had lately over the last year about monitoring and oversight is really what's going to be the difference maker, I think. It's not clear to me what actually happens in these systems to respond from a quality improvement kind of standpoint when we hear these kind of stories today. But to me, we really need to develop that oversight system and some way to instill quality improvement rather than just counting on building the system out and assuming it will work the way we want it to work.
Thank you, Dr. Snowden. Thank you for tying that to the work that we have been doing that we need to do as a committee. One of the things that I'd like to ask folks to noodle on before we get back together in July, it was a question I was going to ask today, but we're going to need more time than we have today to discuss it, which is what are those gaps that we need to address now that we've learned a little more about crisis response for youth, and Dr. Snowden's point about needing to do more than just count outputs or widgets, as they put it, and maybe looking, I took from that looking at outcomes more. It's certainly going to fall into that gap category that we should talk about more in July. Kashi.
I got a lot of time, so I'll be really quick, but just to echo or follow what Dr. Snowden said, it does make me wonder sort of about our data collection, right? Like Starlene shared a powerful example of making 3 calls to 988. How was that data collected? What does that look like? Did those 3 get marked as over the phone resolution? Because I'm relatively confident and happy to be corrected publicly that did not feel like resolution to her and to her family. So what does our data look like? How are we capturing youth in this data? How are we capturing third-party callers? And what are we defining as resolution or success?
I just want to add to that, Kashi, that when Starlene and I talked yesterday and she shared the story with me, and I think she mentioned it today too, that the initial steps in the call involved entering a lot of demographic information, which I think she mentioned that took a lot of time to get through that before she could even connect with a human. I've heard other people mention that as well. So that's another kind of wrinkle on the data collection and piece of things that we've been discussing so much. I see Puck's hand.
Yeah, I'll try to be brief. I'm having a lot of feelings. I remember that when we started this process, we talked about how the system needs to be responsive, how it needs to be able to accept feedback and adapt based on that feedback. And I think about all of these stories about things that went really bad for people and how we're only hearing about them because people had advocates who were able to bring them here. And this is why I stepped away from the story project as it is, because we need to hear from the people who don't have advocates. We need to figure out how to repair things for them. We need to figure out how to help them trust the system. And that can only happen by addressing the things that went terribly wrong. And instead, we're turning them away at the ER after 988 told them to go there or whatever. And they get lost, and we need to figure out how to reach out to the people who are lost and how to also help them, in addition to those of us who have advocates who are here to support us.
Thank you, Puck. I see a note here from Bipasha that came in just as you were talking to, saying, can we track why a call was not connected to MRSS rather than just when it was? And the part when people were not, and I infer from this, were not connected is what you will hear from lived experience folks, which is why their input is essential in building out a good system. One more comment from Bipasha, and then I think we'll have to wrap up our group processing for today, but I commit to you that we'll spend some more time on this in July. Bipasha is responding to what Alicia said. Yes, on getting people help with behavioral health issues when they call 911 or enter the crisis system in any way. And the bigger goal of 988 is to move behavioral health calls to 988. If 988 is to meet the needs of the community, we need to have a very strong mobile response, which in some ways 911 has via law enforcement and fire departments, and more recently behavioral health. 988 is not that strong in the someone to come part, and that needs to be made much stronger, not just for suicide or high acuity crisis, but for other types of crises too. And as ever, Bipasha, you always do such a good job of closing us out beautifully. So thank you for that final message. And one last thank you for such a great panel today. I think this was really fantastic information and all of your work to plan it and moderate. Wonderful. I would like to turn it over now to Representative Orwell, who has an update for all of us on what's going to happen with the CRIS Committee after January 1st, 2025. So Representative Orwell, if you're ready, you're up.
Thank you. I apologize. I'm in my car. I just have to say, you know, such a powerful meeting, and just hearing the stories and the feedback reminds us how much more work is ahead. And, you know, the vision of having a trauma-informed, responsive, culturally sensitive system is the right vision, but there's a lot of work to get there. And I just want to say thank you to everyone who shared the story. Pasha, I really agree with the words you said, because we have a window here to really have people have the experience where they have faith in 988. And I do think it's not a dispatch system. It's supposed to be a clinical intervention, and people need to feel heard and seen and connected for it to be effective. I guess and then again, a place, someone to respond and a place to go. And you know, when I did the bill last year on the rapid response teams, you know, to be an alternative to 911, we have to be responsive. And I think it needs to be dispatched from the 988. So again, I think there's a lot of people working on this. I want to say thank you. I also just want to really recognize the last 3 CRIS meetings. They've all been important, but have just really been exceptional. The panels and the people that have participated, it's just been a great dialogue from the group. And I just want to recognize overall, just, you know, when 1477 was passed with this team effort, you know, the hope is that we would have these type of dialogues. And so I want to say thank you for all the work that's been done. And of course, the coordination that's been done through HMA. So it's interesting. It's like, well, what lies ahead? And I guess the first thing I just want to say before I kind of say the more technical is that these dialogues need to continue. And I think we need to figure out when they happen, how they happen, and continue to have them shape the system. Because if we lose that, you know, this isn't just about implementing a bill. This is about building a new system. And again, you all are an important part and will continue to be. So in Senator Dinger's bill, and I guess she's not on today, but she had language about transitioning the system. And so I wasn't part of that process, but my understanding is that it really is moving a lot of the functions that HMA have been doing around this group and coordination of the system to the Healthcare Authority and DOH. And so my understanding is that the CRIS and the steering committee continue to the end of 2026, and correct me if I have that wrong, and that the reports and stuff that are due, HMA will continue to do those, the end of the year committee report. Is that correct? That you'll be doing that report and the recommendations off the CRIS committee that are due at the end of this year?
That's correct.
I think that is correct. So, but I think the transition part is, how do we continue to have the feedback? My understanding is that the subcommittees aren't necessarily continuing, that the steering committee and CRIS is continuing. But at the same time, what's happening, and this was also through Senator Dinger's bill, is that they're trying to pull in the regional levels, right? And the regional levels will be very tied into 988, the rapid response team, and a place to go. And I think we have kind of an unusual transition of what is the role of the CRIS committee as we've extended it through 2026. And I think it'll be to continue to give input of what's happening in the system. There's the platform technology, just how 988 is working. I think there's going to be a lot of, opportunities for input, but my sense is the system is kind of moving towards these regional reports. One of the things that I feel really passionate about is how do we keep all the voices of people with lived experience and the voices like we're hearing today. And I do think we need to continue to work on that. And I'm committed to working with HCA and DOH of how we can make sure that that continues. And so, it's interesting transition. I appreciate all the work that's been done, but I know there's a whole lot more work ahead. And I don't want this group to feel a lot of confusion or think that we're not committed to continuing to move things forward. I think part of it is having our agencies kind of take a bigger lead role. But Betsy or others, I wasn't part of the initial discussion. If you think I haven't captured it in the way that you understand it, and again, thank you for the work you've done to really get this up and running. But is there anything you would add on that front?
So thanks, Rep. Orwell. I think that the bottom line message that HMA has received is that the work is transitioning to HCA next year. And you're correct, CRIS will continue in some capacity. But the subcommittees, because they were in service to the report and the recommendations, will no longer be operational. And I'm hearing you say that you have a commitment to lived experience and trying to work with HCA to figure out platforms and tables for feedback and dialogue to continue. But in terms of facilitated subcommittee meetings, my understanding is that those will no longer be happening. And then it will be, over to HCA. And Tisha, if you want to speak to any plans going forward, please jump in, because this will be a transition from the BHI with HMA, as the contractor facilitating these meetings to HCA.
Yeah, I'd be happy to. Thank you, both Representative Orwell and Betsy. I do think when the healthcare authority takes over the facilitation of the CRIS starting in January, it probably will look different than the meetings that HMA has been facilitating so far. And I would just agree so much that all of the meetings, but I think the last few have been extremely powerful with the presentations and the information, and they've just been very rich and rewarding meetings, which is fantastic because the importance of having the subcommittees be able to put forward the information so that HMA can write that final report with the recommendations is so critical. I also think it's then thinking about, starting in January of 2025, as we're hopefully moving into more of a giving updates and how are things going and looking at more of the kind of that implementation phase, then what do these meetings look like at that point? I don't think we've kind of figured all that out yet, but we're certainly trying to move forward and figure out how we are going to staff and resource and continue to provide the facilitation in the final year.
So Tisha, Representative Orwell, Betsy, it sounds like more to come as those details are worked out. Is that right?
Okay.
You got it.
Thank you. All right, we have one person signed up for public comment today. I do have just a quick action item for everyone. You heard an update earlier from Kristen and Bipasha regarding the Lived Experience Stories project. We do have a flyer for you that's been uploaded to the CRIS website. I think Christine or Nicola are going to put it in the chat for everyone. So please look out for that. And then CRIS committee members, please continue to think about and process what you heard today with the Youth Behavioral Health Crisis Response Panel, so that we can come back to the discussion we were having today and expand a little more, start really talking about gaps and what we want to address with gaps. So, like I said, we have one public comment today. We'll do it with the timer. I'll put the timer up on the screen. Our commenter is Melody Yelker. Melody, please forgive me. I know you've told me the correct pronunciation of your name, and forgive me if I mispronounced it.
Always.
What was that?
I said always.
Always. Okay. Yeah, I believe me, I'm sympathetic. I have the same problem. I'm going to share the camera on my screen, and we're going to pin you to the screen, and you'll have 2 minutes to make a public comment. Just a reminder that the CRIS committee is not going to be responding to your comment. They will be listening, but not responding. And if you have any written versions of your comment, please feel free to send it in an email to the email box. And that will help us make sure we get it all clear for the record. So bear with me just a moment as I put the timer up. And please go ahead and start talking whenever you're ready.
You know, when I listened to everybody's stories today, I live those stories with these parents and with these kids every day where I work at. And you know, when someone mentioned about it's not just the child being in the crisis, but it's the parent being in crisis. That is so true. I never heard that before till today, but that's absolutely true. And, you know, they have exasperated community, the communities, what they have to offer, or they can't access it. And they are calling 911 or they're calling 988 for help. And, you know, and unfortunately there aren't places out there that they can take their kids to, and or for these kids to be, you know, taken into. There's no beds available, particularly for 12 and under. And, you know, they end up my place, and that's at Martin Hall Juvenile Detention Facility. And I hear, you know, which is only just traumatizing both the parent and the family when that happens. And then it just starts a long relationship of criminal activity, which doesn't need to happen. You know, Starlene, I could really understand what she was saying about, you know, where to go next, and not being able to, you know, there's supposed to be these services out there, but then there's not. You can't find them because they're not. But I'm encouraged about this committee, CRIS committee, that, you know, unfortunately we might be losing the lived experience stuff. Though we're just starting the iceberg of. You know, there's a big iceberg of lots of things we need to do. And this is just the start, even though we're probably like 3 years into it. But I am encouraged about what's to come. And I just want to tell you guys that I really appreciate everybody's work. And thank you for keep coming and doing what you do.
Thank you, Melody.
I have so much more to say, but 2 minutes is too short.
Well, please do send any written comments in, and we'll make sure it becomes part of the record. And also, I just want to acknowledge, I know you are a regular attendee of these meetings, so thank you for being part of this. And thank you to all of our community members who come and give your time every month to this. Thank you to our CRIS members. You are tremendous. It has been a wonderful 3 years, and I am privileged to work with you. And a big thank you to our panelists today, to our presenters today who worked so hard to present great information. Today's meeting in particular, I think, represented a substantial and large group effort. So big appreciation to all of you. I know these panels have been really valued by many CRIS members, and we're grateful to have the opportunity to hear people's expertise. And with that, I'll say goodbye to you. We'll see you in July. Everyone take care, be well, enjoy the almost summer, and we'll see you in a month.